Rafael, we are getting started. Good morning, everyone. We can't hear you. Your mic's not working. Agora. Good morning, everyone. It's such a pleasure to have you here. We would like to say welcome to everyone and welcome the ones listening to us through the EEA-USP YouTube channel. Thank you so much for being here. Thank you for enrolling. We had more than 150 enrollments in 1 week. We are so happy that every stakeholders in the precision medicine ecosystem are interested in our event. We are so happy because this is our inaugural event here in our EA. Our research group is called EETOP, Equity and Efficiency of Precision Oncology Technologies. And we aim at enhancing the discussions of academia with society. And we wish to enhance discussion, especially on the potential, the power and the challenges precision medicine brings to our health system. And this discussion is focused on equity and sustainability of the health system. We know of the promises technologies of precision medicine bring. And we are favorable to innovation and using it in the health system. But we are worried with its sustainability and equity. These technologies need to be available to the most vulnerable people, and they are the one who needs this technology the most. This group has this challenge to enhance the discussion with society, to have all the important stakeholders in this ecosystem together so that we can discuss and know how to implement the health services in our unified health system in Brazil. Thank you so much for being here. I hope we have 2 fruitful days that will bring many good things for our health system. Thank you. I'm Patricia. I'm sorry. I saw so many people I know that I forgot to introduce myself. I'm Patricia Soares. I'm professor of preventive medicine in the São Paulo University Medicine School. Now I coordinate this research group. I'm sorry, I forgot to introduce myself. Now Claudia Pavani, which is the vice coordinator of our research group, she's going to talk to you. Thank you so much. It's such a pleasure to be here. It's such an honor to start this group, Equity and Efficiency of Precision Oncology Technologies. We know that our health system is huge. There are 100 million people that we serve. And there are many problems that are problems where we can't reach. And these technologies are promising. They have awesome impacts, but they are so expensive. And the question is, how will we be able to think on this technology for everyone? So this is our challenge, and this is how we wish to contribute for this discussion. So the stakeholders' participation, all of them, is basic. This study group aims at bringing voices from the outside of our group. And our work is incipient. You have our emails, top@usp.br. We will talk to you and we will agree how this participation will happen. I would like to say thank you especially from the EA group, people that were in the backstage and make it happen. Georgie, Edilma, Sandra, Marlene. I will say their names because they are so important. Our Super Raphael, the interpretation people who will be there. Aziz, the technical people, Carol, Sophia, Natasha, and also the ones that helped make it happen. IATS, they are a great partner of ours. Thank you so much, IATS. And Professor Roger Summers in special. Thank you so much. We'll have fantastic days here. No doubt about it. Now I hand it over to Maria. As Claudia started acknowledging people, we need to say thank you so much for Seduz PPO, Professor Jorge Chamas. He helped so much, and Preventive Medicine Department, Carol, Sophia, and Natasha. You have been helping us so much. They have coordinated the emails, and they helped so much in the organization. Before I hand it over to Maria, I would like to say this research group is fruit from a study group that Professor Maria coordinated before. It was called Science, Technology, Innovation in Health. So we came from that study group coordinated by Professor Maria Novaes. This is why I'm so happy today, because she's a colleague from another department. She's a professor, but she's my friend. It's so nice when we can work and research with friends for so long. Thank you, Maria. Good morning, everyone. Welcome. I'm so happy to be here. I'm so happy to see you all. I asked people from many institutions and places. We'll be able to have a debate. This is the idea of this event, that people get to know each other. And we need to talk the more the better. I'm Elegonda Maria Novaes. You know me as Maria Novaes Simpler. And I'm a senior professor here in the Preventive Medicine Department. I have been working with AGTA for such a long time, and health services as well. This is, Patricia has guided us. I mean, we need to understand the AGTA and its impact for the health system. In order to do so, we need a coordination between the developers, the producers, the professionals, the services. So everything needs to be well adjusted. This interdisciplinarity needs to happen, and we need interprofessional, intersectorial work. Every it's needed, and this event is fruit of this huge work and this perspective. We are so joyful to have here with us Ouija Ordwin. She's so known internationally. She was the president of AGATAI, the International Association of AGTA. And now she is the president of the appraisal committee. It's a Conitech empowered of the national health system. She's such an important person, and having her here is fantastic. She's going to tell us how they have been living the arrival of technologies. and its impacts on the practice of HTA and these incorporation processes with equity and sustainability. Ligia, please. Ouija, please, we would like to listen to you. Thank you.
Thank you, Maria. I'm very, I would say, shy with your humble words about me. I'm very happy to be here. That I have to use reading classes says something about my age, so I hope I can find my presentation here. I think this one. Right? Yes. So first of all, thank you so much for the invitation. I'm very delighted to be here and share my experiences, especially my experiences, and of course also my knowledge that I gathered in more than 30 years working in the field of health technology assessment. And it was very nice to hear Maria talking about her work in the field of HTA even before I actually entered the field of HTA in 1993. And she worked with my supervisor, Professor David Banta, who actually is the godfather of health technology assessment. And I was actually very lucky that I met him during my journey when I just graduated, and then that he was a professor in our university. And this is also something that I think is so important, that you meet people around the journey that you have and that you collaborate with and that you share your knowledge and bring the knowledge and the experience that you have further. So that's also why I'm very happy to be here. I work with Patricia and Maria on the program, and of course we felt that it was interesting to have some reflections about indeed why there is a need for health technology assessment, but specifically also the views of stakeholders within the assessment of technologies, and in this case precision oncology. But of course it could be every technology that we are talking about, and this is also what I teach my own students in the university, but also in the appraisal committee that I chair, because every month we also have different technologies that we have to appraise, right? Of course these are a lot of oncology products, and that same goes for other HTA bodies around the globe, because these technologies, and especially around precision oncology, are emerging quite rapidly. So this is also what we see, an influx of very expensive, especially drugs. Oh, thank you so much. And these do come with some challenges, and I also like to touch upon those. How can we indeed make a very informed, deliberative assessment and appraisal of all these new technologies that are indeed incoming to our health systems. And of course, not only low and middle income countries struggle with these challenges, also high income countries like my own are increasingly struggling with this. So how can we indeed make informed decisions that do indeed balance the sustainability with the equity considerations for the populations that we serve? And of course, we spend more of our GDP on health, but still we do have more or less the same challenges. So it is about making these making these choices, and do this in a legitimate way, so that we can enhance the fairness of the decisions. And this is actually what my talk this morning is about. There is room for questions afterwards, so please do feel free to open any question or reflections that you might have. And if you don't want to ask them during the meeting, I'm also here for today and tomorrow, so please feel free to come by discuss anything that you wish to do so. So I would like to give some acknowledgements to my two colleagues, and especially one of my colleagues, Bart Bloemen. He's my PhD student. He is actually just finishing his PhD work on normativity of health technology assessment, and I supervise him together with my colleague Gert-Jan van der Wils. So part of my presentation is based on this article that was published earlier this year in Healthcare Analysis. So there is some more background in this article if you wish to learn about that. So coming back, let's start with the definition of health technology assessment. What is actually health technology assessment? So I would like to highlight a few things here. So it is indeed about what Maria already alluded to. It is about multidisciplinarity. So we need different expertise in our community to join together in order to determine the value of health technology across the life cycle of technology. So it's not only about, for example, health economics. No, we also need indeed the clinicians or the epidemiologist or the ethicist or the social scientist or those that have experience with patient-based evidence in order to determine what the value of health technology is. And like I said, the aim of HTA is to inform decision-making. It's not to replace decision-making, it is to inform. So we, as HTA researchers, we deliver the evidence and the information in order for example, advisory committees like myself or ministries of health to appraise the technology to indeed define what actually is the value of this technology for the population that we are targeting. So it's very context specific. So every single country or even region within a country might have different value frameworks. So we need to be very attentive of this. So there is no size fits all. It's very important to understand this from the beginning. So in order to make these value judgments actually, because it's about determining the value, it is actually that we say something about what are actually desirable or undesirable outcomes of the technology that is under consideration. And technology can be everything. So it's not only drugs, it can also be medical devices, it can be public health programs, it can be vaccines, it can be surgical procedures. So the health technology in itself is also broadly defined. In this case, we are going to talk a lot about precision oncology, and of course there are a lot of drugs, but also diagnostic tests involved in that specific area. But just to let you know that this is a broadly defined term. And like I said, when we make such a value judgment, it has moral consequences, meaning that once we spend our reais on one technology, we cannot spend it on another one. So in this means that we say something with a normative connotation. And so we actually prioritize a certain technology above another one. So we have to have this in mind. It is about distributive justice that we are informing with health technology. And that's very important. So when we look at these highlighted terms, I would like to emphasize that the life cycle is very important, and I know Maria is also going to say a few words about that. So what do we mean by life cycle? A life cycle is actually the diffusion of health technology or technology in general that you're probably all aware of, and HTA can be, or the evidence generation and the appraisal of evidence can happen during different phases of the life cycle. So HTA can happen prior to a market approval. So you can, for example, think about hospital-based HTA because a lot of innovations take place in a hospital, and also hospitals have to make decisions, for example, which medical big technologies, for example, MRIs or new diagnostic tests, they want to procure in their hospitals. So prior to any marketing approval, there might be certain decisions to be made. Of course, at market approval, the regulatory authority plays an important role. A regulatory approval is not the same as an HTA informed decision, but they need to work very closely together. So what we see, especially in European countries, but also at the European level, is that the European Medicine Agency now works very closely with the HTA agencies in the European Union, because we do have a new law on health technology assessment, to align the scientific advice, so for market approval, so what kind of evidence is required for the market approval, that aligns with what kind of evidence a manufacturer needs to collect for the HTA dossier. And these are different evidence requirements, because the mandates of a regulatory agency is different from an HTA agency. But in order to improve the timelines, the regulatory agencies now try to work more closely with the HTA agency. Of course, after market approval, it does not mean that the technology is available in terms of reimbursement. And something can get regulatory approval, and it is available, so it can be, sold on the market. But that not necessarily means that people have access to it, because it's not reimbursed. So in order to have this pricing and reimbursement decision, HTA comes into place. So this is also where there is where there might be new evidence requirements for the pricing and reimbursement decision, and this is very much dependent on the country that the manufacturer is applying pricing and reimbursement for. So this is very important to note. HTA can also be used, for example, to optimize healthcare systems. Maria alluded to health services research. So the collection of evidence about appropriate use, so the alignment with clinical guidelines here, is very important. So for example, in the Netherlands, our national HTA agency, it's called National Healthcare Institute, Zorginstituut Nederland. They also are not only responsible for the HTA evidence collection, but they are also responsible for the optimizing the appropriate use in practice. So they also work very closely together within the institute in order to collect data that improves, say, for example, adherence to clinical guidelines, and if there's no adherence to clinical guidelines, to see how they can work with the medical practice in order to optimize this. So there are different policy instruments that are very important in this ecosystem. So HTA is used to support, not to take over, but to support the decisions in the whole ecosystem of the healthcare system. And it differs from country to country how this is organized. Like I said, in the Netherlands, this is, for partly it is in one organization, but in other countries it can be in different organizations that collect these data. And this, of course, they need to collaborate. So it's very important that we do not see health technology assessment as one single entity. No, they also need to, we also need to collaborate with all the stakeholders in the ecosystem in order to indeed improve the sustainability and also the equity of the healthcare system. So it's not only dependent on HTA. That's the main message here. Then, when we talk about value, so the determining of the value, like I said, there might be different components here that you can think about. And you can think about a dimension of value, for example, what is the effectiveness of this technology compared to the alternative? Because in contrast to the regulatory approval, HTA is always comparing it to an alternative, to the existing alternative. That can be standard of care, it can be an existing treatment, but it can also be, for example, the choice of treatment by a practitioner when there are no alternatives or multi-alternatives. So it also depends what the comparator is. And the choice of the comparator is very important in HTA. When you design your dossier to be assessed. It's not only about the intervention, the new intervention, but also about the comparator or the comparators, right? So we all know that once you design your PICO, the comparator is very important. And especially that might also differ from country to country, because the comparator, what standard of care is in the Netherlands, might not be standard of care in Brazil or even in Germany of our neighboring country, Belgium. So this is also very important to understand. And what you conceive as value is very dependent indeed on the value framework that countries use. So I listed here, this is from the definition, that there might be multiple value dimensions like clinical effectiveness, like the cost effectiveness, like the ethical or legal considerations that people would like to take into account. Or maybe you want to indeed look at the organizational aspects, very important for, especially for hospitals. So do I have the workforce that needs to work with this new technology, for example? But also more increasingly people understand that we also need to look at the perspective of the patient itself. So patient-based evidence is increasingly used also in how we determine value of technology. So what are important outcomes from a patient perspective in addition to a clinical meaningful outcome? Because something can be clinical meaningful, not necessarily means it's also meaningful for the patient. So this is also something that is increasingly known. And like I said, it really depends on the perspective that you have. You can take a societal perspective, which a lot of countries do. But if you are in a hospital, you take the hospital perspective. So this is important to know that the perspective is also dependent on, the assessment also depending on the perspective that you take. So the national, the regional, or the local context might impact in how you assess things. So if you read a report, it's always very important to understand what is the context here, what are the values that are underlying value frameworks. For example, why is indeed the UK or NICE in the UK focusing on cost effectiveness and clinical effectiveness, and why is Germany only focusing on clinical benefit, for example? This is because they have different value frameworks. And that's why you cannot necessarily always compare these HTA reports from one country to another. So you really have to be critically appraising also the evidence that you use. And this is also something that we use in our appraisal committee. So we look at different countries, whether or not, for example, certain technology that we appraise is already reimbursed in another country and under what conditions. But we not necessarily use all the evidence that they have used in their assessment, because we do have different value frameworks. So we look at it, we inform ourselves about it, we try to understand how they came to a certain value judgment, and we just relate to ourselves. So this is how we actually use the evidence from other countries. Like I said, there are different stakeholders here, and so in the definition you can see here, it depends on who you ask what the value is, right? If I would ask a certain stakeholder what value is for him or her, it might differ. So it's very important to understand who the stakeholders potentially are, who were involved in the process, and also how they came to this value judgment. This is an example. This is TAPI, which is the replacement of valves for aortic stenosis. You probably are aware of this. And when you ask yourselves, what actually is the value of this technology, or you could ask the question differently in terms of what kind of outcomes do we really want to achieve with this new technology compared to the open heart surgery, which is the standard of care here. So what is actually what we want to avoid or realize by introducing this new technology in our healthcare system? Why do we want to pay for this new one compared to the other one? And there might be different reasons. For example, you might want to say, for me it's very important that we would like to avoid the risk of open heart surgery for this specific, of course, sub-indication what we are looking at, and the target population here is very important. or we would like to avoid mortality. We would like to increase the life expectancy of these people with aortic stenosis. Or we would like to improve their quality of life because, you know, the people with severe aortic stenosis, they of course suffer a lot and they might not be able to conduct their daily activities anymore because they are, you know, short of breath. But also we might want, and that could also be a value judgment, we would like to avoid high costs because the TAVI is less invasive procedure compared to an open heart surgery. So potentially it might have less cost than open heart surgery, right? These could all be kinds of considerations if you would like to, you know, if I would ask you to allude about what do you think that, or what do you perceive to be the value of this new technology. And it depends actually what you think is the added value, because if you would ask a clinician, he potentially would focus on the clinical effectiveness. But if you would ask a decision maker, he potentially would, you know, focus more on budget impacts. So this potentially could differ, right? And therefore it's so important that we have different perspectives in order to understand what is the added value here at stake. And these are all normative considerations, because if you look at these different potential outcomes that you might want to consider in your health technology assessment, you can see we focus here on safety, we focus here on effectiveness, and we focus here on cost effectiveness, right? So you can see that these are related to these concepts of the value that I just mentioned here. So clinical effectiveness, safety, and cost effectiveness. So you can clearly see these outcomes are related to those. But if we look at safety, if you really look at what does this mean, avoiding adverse events, actually it's a kind of outcomes that we wish to avoid because we would like to avoid harm. That's an ethical commitment or a normative commitment actually, because doing or avoiding harm is the ethical principle of non-maleficence, right? And if you look at effectiveness, this is indeed about doing good. We really would like to achieve an outcome that is good for the patient, right? But that's also an ethical commitment actually. So it's a normative dimension of clinical effectiveness. And there's also a normative commitment in cost effectiveness, because indeed we would like to show that using TAVI potentially leads to more cost-effective care, and therefore it might improve the financial sustainability of a healthcare practice. And that's a commitment to distributive justice. So we believe in maximizing health for the population. That's the principle that is underlying cost effectiveness, but it's often not made very explicit. But actually that is something that is normative in itself. So just to say that ethics or normativity is always included in these domains when you're going to assess a technology. So we think that we are talking about facts, which is true. I mean, that's also a normative judgment of myself. But you think that you are talking about facts, but there's also a value judgment in it, in itself. So implicit, it's there. So we always say that it's not ethics and facts, but it's ethics in HTA or in facts. So the facts and the values, you cannot distinguish them. That needs to be very clear. And this is something that is also has these moral consequences. So the question, of course, is when I'm focusing on these three components, the question is, and this is also what we see a lot around the globe, is that these three value dimensions, safety, effectiveness, and clinical effectiveness, are most often used by countries in order to make value judgments about whether or not to reimburse, for example, a technology. But the question, of course, is, does these three components really address all aspects of value of a health technology? And does this also address all the relevant questions that stakeholders might have? Like I said, safety and effectiveness are mostly those that are focusing on I would say, the perspective of clinicians, sometimes also of patients, but patients might have more questions. And cost effectiveness is very much the focus of healthcare decision makers, so insurers and ministries of health, especially when it comes to financial sustainability, and those that are taking care of the budget. So if you think about, for example, a technology like genetically modified embryos, I'm going to ask this question to you to think about. Do you think that we should do this? Who in the audience think this is a good way to go about? I see no hand raised. But we do know that happened, right? It happened some time ago, and there was quite a public arouse about this. So the question, of course, is indeed, why should we do this? Huh? So these are also fundamental value judgments, right? So why do some, stakeholders wish to put maybe parts of this, I don't know, genetic, maybe not modified embryos, but there might be some value in looking at, genetic profiles. We are going to talk about this, right? But you can see that also research in certain areas like genetics might also have unintended consequences, right? And this is exactly also what HTA is about. It's not only about, what are we trying to achieve, but also what are we trying to avoid. So this is also very important. So these are questions that you might ask yourself when, new technologies are influxing our healthcare systems. And I do know that a colleague from Brazil will talk about horizon scanning. So once we see all these new technologies coming to us, the question should not be, do we need to pay for them? But the question should be, do we really want to introduce these to our healthcare system? And why do we want this? This is another example. Of course, this is also very much related to precision oncology. So we all see new fields of sciences emerging, and we call them also NBIC technologies. And this also is a field that we cannot stop. I mean, this is something that is ongoing, and it's a very dynamic field. And while we are talking here, new technologies are emerging. So there will be new technologies developed as we speak. But the question, of course, is how to prioritize these. And it's also related to horizon scanning, but also the prioritization within, once you have an overview of technologies that are coming to your healthcare system, how to prioritize these. What is good for my healthcare system? What is good for my healthcare system might not be good for your healthcare system. For example, I work a lot also in middle-income countries, and I work, for example, since 20 years in Kazakhstan. And when we started with also trying to establish HTA mechanism in the country, I asked them, okay, based on your needs and your healthcare needs, so your disease burden, the priorities of the country, maybe potential budget impact, and those technologies potentially can be very disruptive. What would be the first that you would like to focus on? And I thought maybe they will come up with prevention programs for tuberculosis, because that's very prevalent and that's a huge social problem. But they said cochlear implants in children. And I said, why? Because I didn't really understand the rationale for that. But they said, well, because, in one of our university hospitals, this is a very new technique, and we really would like to, work with this. But I said, how does this relate to your healthcare needs? So these are questions, there's no right or wrong, but there are choices that health systems can make. So you always have to trade off the rationale, how to prioritize. So where do we also put our research money in? So why would we invest in precision oncology? Or why are we going to invest in diabetes research? Or why are we going to invest in research for addressing neonatal screening? These are important questions that we need to ask ourselves, related to the values that are underlying our healthcare system, but also indeed our disease burden in the society. And like I said, the disease priorities of the Netherlands can be completely different, even from a high-income country in the same in Europe, because we do have different problems in our healthcare system, different challenges that we need to address. So this is very important. And also, indeed, the value judgment of society. Societies can think differently about certain technologies. And for example, I also once did a study about palliative care at home in 7 European countries, and how societies perceive dying at home can be completely different from country to a country, depending also, for example, on cultural differences that are related to religion. So you also need to take that into account. So to say, okay, we are going to introduce palliative care at home is very imperative. That's not the question. The question is why indeed, or what will be the impact on the society? What is the susceptibility of the society or the uptake, even in a society, but also, for example, in a hospital? And so how do the medical professions or health profession in general think about the uptake of this new technology in our local hospital? I also work in a university hospital. So we need to understand the context. So that's very important in health technology assessments. The same for precision oncology. I did a little search, but you probably have more more examples. And so we also know that precision oncology is going to change, already it has changed healthcare practice, because since decades we are now focusing on precision oncology. And it also shapes the thinking that we have with regard to what is health and what is disease. And we see that with new, because of the new drugs, not only for within precision oncology, but also in other areas, that the life expectancy has increased a lot. And for example, last week with the appraisal committee in the Netherlands, we focused on multiple myeloma. And there is a lot of also developments with regard to new drugs in that area. And we saw that within 4 years, the life expectancy had increased with 11%, which is quite a lot in this group, because the disease burden is very high. And the median life expectancy increased from 5 to 7 years, for example. So these are very important changes. So instead of focusing on having the disease and focus on life expectancy, we also need to focus on how to deal with this survivorship in this period, to increase life expectancy. What does this mean in terms of quality of life that people have? And how can that be taken into account when we do our HTA? So this is very important. So the new developments also give new hope. And what is the value of hope, for example, for patients? How do we take that into account in our HTAs? But of course, also, how do we deal with the cost? And I think you already alluded to this. I mean, we also see that these new drugs are related with high prices, and how can we balance this, the value with the the added value of certain drugs with indeed the prices? And so how can we make this sustainable? Not everything can be solved with HTA, like I said, and these are sometimes, I mean most often, political decisions, right? But as HTA we can at least make very clear what the potential trade-offs can be and what potential impacts might be for the society. I talked a lot about ethics in HTA, so the normativity in HTA, but there's also normativity in how we do HTA. So we also, I already alluded to it a bit about this, so how do we make these informed decisions? So how can we make these trade-offs? So maybe who should be included in these decision-making frameworks? So what is the voice, and how can we indeed give equal voice to everybody? Because what I talk about is about legitimate decision-making, and legitimate decision-making is the fairness as perceived by stakeholders. But these stakeholders, and we call them the 7 Ps that I showed on the slide, also then need to have an equal say in this. So it's not, like I said, imperative that one person says, okay, I'm going to tell you what to do. For example, in my appraisal committee, in my case we are 9, and I know that in Conitec there are more than 20. How do you make these informed decisions? How do you give equal voice to everybody that is at the table? And already, how do we decide who will be at the table? Who actually is going to do this? So this is also about ethics of HTA. So we need to also be very transparent and follow certain rules that are very clear to the society, and the society has a say in this as well. Potentially that would be good practice in order to make informed decisions on behalf of the society, because this is about public money and we are making recommendations or decisions on behalf of our population. Most of these populations have paid tax for that. So we should not forget that we make very important normative or decisions with moral consequences for the population. And that's why a task like, for example, the appraisal committee is a very important one. And we feel, really, it's not easy to make these choices or, to make these decisions or these recommendations. Because when we say yes to this drug, we say no to those that are not visible at the table, or not, all the other patients that are not being discussed at that moment. And these are very, very difficult choices. But we do, this based on the evidence that we have and based on the values that we adhere to. And we make this very explicit and transparent, and we report on that. But this is also about ethics of doing the HTA. I will come back to the data, because that's also very important. So what do we perceive as reliable evidence? That's another very important question here as well. So understanding normativity is actually that HTA can be understood as commitments of involved stakeholders regarding what are conceivable and desirable outcomes. Like I said, what do we want to achieve, or what do we want to avoid with this new technology? But also, how can we gather reliable evidence for that? And whether or not this technology is going to deliver on the promise, because we are often talking about technologies that we have, research in clinical trials, and we also all know that this is not healthcare practice. So how do we perceive this as, or what do we perceive as reliable evidence for this? And these normative commitments can guide HTA doers and those that collect the data in making also methodological decisions about, indeed, how do they assess all of this, and committing themselves to what we call then underlying moral, epistemological, and ontological norms. And I will spend a few minutes on this. This is also what I'm going to talk now, described in more detail in the paper that I showed you on the first slide. But this is very important because we also, as HTA doers, make all kinds of choices when we do our assessments. And I don't know how many of you do really assessments, but when we collect the data, we also make choices. Which review do we include in our evidence base, for example? And why do we do this? These are all choices that might have an impact on potentially your outcomes of this assessment. So this is very important to understand. So the normative framework actually of doing an HTA also influences how they are assessed and also what conclusions are drawn with regard to the evidence. So if we talk about moral commitments, actually that is what I already alluded to as commitment to norms concerning what makes a health technology desirable and acceptable. I already talked about this. Actually, in ethical terms, you could say how the world ought to be. So, and what really do we would like to achieve with this new technology? I would think I can skip most of this, but actually, for example, if we are talking about cost effectiveness analysis, often one standardized a questionnaire is used, the EQ5D. This is also presented in most of the methodological guidelines of HTA agencies. You know, for manufacturers to submit a dossier, they have to use the EQ5D for conducting their cost effectiveness analysis. But actually, when you look at the EQ5D, there is also a normative dimension in it, because the EQ5D is 5 questions, but actually they imply what aspects of life are desirable for, you know, because you are going to ask patients to fill out this form. You know, are you able to walk 10 meters, for example, or how well can you walk 10 meters on a scale from 1 to 5? There's a normative dimension, because it implies that by walking, this is having a good life or an aspect of life that is desirable. But we also know that this might not be completely applicable to a lot of diseases, right? Because if you, for example, have hemophilia and you are in a wheelchair, this dimension is not completely, you know, very, I would say, applicable to this patient group. So it's very important to also think about other dimensions that can be useful from a patient perspective, and that's also what I already said. In addition to standardized questionnaires, you might also want to include other questionnaires that show value from that specific patient population perspective. And although that is often mentioned in methodological guidelines, for example, it says it is mandatory to use the EQ5D in the cost effectiveness analysis, but if you wish, you can also include evidence from other standardized quality of life questionnaires. This is often not done. The question, of course, is why not? But this is something that we see in practice. I will skip this one. So the second commitment is about, indeed, commitments with regard to the evidence that we use in assessments. And the question, of course, is who decides what form of information counts as appropriate evidence in HTA. And I refer here to the hierarchy of evidence. You all know this, that we all perceive within evidence-based medicine, which is also the foundation of health technology assessment, that randomized clinical trials are seen as the golden standard. But there's now a shift, like I already said, because not everything might be captured in RCT, or not everything can be collected via RCT. If we look at precision oncology, I mean, these are, you know, small populations, or RCTs are, you know, single-arm RCTs, so less, so non-randomized study designs. So they might not be conceived as, you know, the best evidence. So how do we deal with this in HTA? And how do HTA agencies perceive this? Is there a need to then also introduce real-world evidence collected via real-world data, via all kinds of different sources? And this is highly debated within the HTA community, because some HTA agencies around the globe do accept also the use of real-world evidence, so not only, but not all of them are willing to do this yet. So there you can also see that the way HTA community perceives what is reliable evidence differs. And this is a normative aspect of HTA that we should be very aware of. I'm not saying it's right or wrong, but there are differences in what we perceive reliable evidence, and that really has an impact on the conclusions that you draw. So therefore, you need to be very aware of this. Okay. Then the last one is ontological commitments. This is indeed more about the commitment that indeed we would say in the acceptability of outcomes by different stakeholders. And so how do we perceive, for example, health and disease? And do we all have the same concepts of what actually are we trying to solve here? And so what is the underlying problem here? So I give an example of cochlear implants because my study group focused a lot on this. And by the introduction of cochlear implants, which is a device to try to restore some of the, not to restore, but at least to make the hearing a bit more functional, especially in prelingual deaf children. The question is, indeed, what problem are we trying to solve here? Might be quite imperative to say, you know, every child that is prelingual deaf needs to have a cochlear implant. Because by doing this, and not asking, for example, the deaf community how they perceive this, you might miss out very important opinions or viewpoints on the successibility of this technology, because the deaf community, when at least we introduced this technology in the Netherlands a very long time ago, 25 years ago, the deaf community was appalled that the medical community wanted to introduce this new technology, because they said, you are actually, you know, dismissing our deaf culture. So this was a cultural aspect here. So they really said, you know, I'm not willing to give up my, you know, deaf community because you think this is the best for my child. So these are very important cultural values that you might miss if you only have one perspective. So it's also very important to indeed involve stakeholders that potentially will be affected by this technology when you scope your health technology assessment. So indeed, what are potentially unintended consequences of introducing this technology in your community? Because if this will not be uptaken by many, then it also will have, I mean, you might have a fantastic randomized clinical trial, but if the uptake in practice is, for example, 0, then the effectiveness is none. So what are we actually paying for? So please think about these questions up front and not once you already have done the assessment. So that's a very important lesson I think we can learn from doing this scoping together with stakeholders. A final slide this is my pre-final slide, is that normative commitments are always intertwined. They are interrelated. And so, for example, moral commitments with regard to autonomy in terms of, you know, what kind of information people would like to receive when they, you know, are included in a randomized clinical trial, is related to also the epistemological commitment. So what kind of information do we actually give to these patients? And I gave here an example that is related to precision oncology. So people should be able to decide whether or not to have a preference for return of genetic results in the field of precision oncology is related to, indeed, that we feel that people need to have an informed, that they can make an informed decision whether or not to take part in these randomized clinical trials. And I think this is also very important because I also do some research together with our neurology department about the use of, not the use, the involvement of patients indeed in the design of clinical trials and what kind of information they need in order to take part in, for example, a clinical trial. which is also very important. It's not necessarily HTA, but it's related to how you design your trial in order to improve the uptake later on. So these are also very important. So when you are doing an HTA, articulating these points, and not necessarily in these, I would say, difficult terms like normative commitment, but just articulating that these are values that are at stake, is very important, because once you know this or can make them explicit, you can also have a discussion about it. And I think this is what I would like to bring across, that it's very important that we express our fundamental underlying principles that we adhere to in order to also understand each other, because speaking the same language is very important, especially when you involve different kind of stakeholders. So to conclude, so HTA is inherently normative. Like I said, it's not only about facts. The facts and values are intertwined, and integrating stakeholder participation and also this articulation of or making these value assumptions explicit across the life cycle is key in order to improve also not only the conduct of HTA, but also in the end how well the decision making is made, because in the end this will enhance decision making from a legitimate point of view. And I will allude to stakeholder participation a bit more tomorrow. So thank you very much. This is a picture from the Netherlands, quite flat, but it's this colorful. Thank you so much.
Thank you, Vija. I think you could sit down. I think you could sit down, and then I don't know what time it is. How much time do we have for discussion? Huh? 12 minutes for discussion? 20? Okay. Please sit down. Thank you very much for your presentation. I think you pointed out many things that are worry us also in general, and related to precision oncology in our practice of deciding about other people's lives. Doctors do that all the time, you know, health professionals do that all the time. On an individual basis, we decide, you know, what's good for the patients. Of course, they have to agree, but they tend to follow what we recommend. And then HTA is on a collective, you know, bigger, higher level, but it's also a practice of deciding about other people's lives. So this is, you really, I beg your pardon? Okay, I'm going to go in Portuguese. Okay. Okay, yes. So translator will be active. Okay. Desculpa. Tem que apertar botão aqui, assim, e tal, e os botões, depois de uma certa idade.
Now we have to shift the button because after some age we are a little more distracted. So she portrayed something really important for us in general. This is a point in our professional lives, and particularly regarding the role of the assessment in health technologies, involvement, participation in precision oncology. What she's put are questions that we are going to see in depth throughout our discussions of knowledge that most of us don't have, but I've been studying a lot in precision oncology. But we have to understand genome, genetics. It's not easy. And we have an audience here that can enjoy and take advantage of this and get to learn a little more about the precision oncology. Because certain names start circulating and being spoken about, but actually we know very little about it. So the concept of this event was that to start putting some general issues and questions that can be followed. After the coffee break, I'm gonna have some questions that we are going to follow throughout this discussion. that is all focused on precision oncology. So we have time for some questions. I would like to know who would like to ask. Please say your name. Who do you act? What's your interest, your study area? We have two here. You can start. I can't hear. He needs to speak closer to the microphone, please. Good morning, I'm Rodrigo. I'm graduated in chemistry and finishing my PhD in clinics. I love your lecture. I didn't know this approach about assessment on technology. My work is a little related to this because I develop nano devices mostly in health area. So I would like to know if you have had experience in applying this concept of HTA for the development of things that are all still on the bench, preclinical, in the development itself. Thank you.
Acho que a gente podia uma pergunta só para
English aqui, né? We're going to have another question. We put them all together. Good morning. I'm Ana Carolina. I'm presently at a coordinator of monitoring in the Executive Secretary of CONITEC. I'm here very glad. My question is not a question. I would like to bring some information to foment this debate. By understanding your need of prioritizing from our health needs and the cost of opportunity of we don't offer when we decide on another, we have a situation in Brazil that we don't have choices, decision making of not serving. It's in our constitution that health is a right for everyone. So we can't prefer something, even though we have a need, a malnutrition. We can work on malnutrition, but we also have to work on precision oncology. So when we think about the meetings of CONITEC, this week we're going to have a meeting, 134. They happen monthly. And this week we're going to evaluate 19 technologies, and there are no limits. Out of these 19, we have budget for 10 of them. But we can't have this discussion because there is no limit for this discussion. So even though we look at these ethical issues that need to be seen beyond the process by bringing this Brazilian reality, how to advance from these parameters.
No, I'm very aware of the utilization of health technology assessment, but in essence we do have the same, although it might be a bit different, because even if, for example, a patient in our case would go to court, which might happen, we will have to see what the situation will be. So every single person in the Netherlands can go to court to appeal to a certain recommendation, although it's different from, of course, the Brazilian way. How to deal with this reality is, of course, a very difficult question, but I think the only thing that you can do is to make very clear that even you do not decide, you do decide, right? Or the ministry decides, or the politicians decide. So And I think you already do this by providing education to the lawyers, and that's also what you're already trying to do, at least that's what I know. And then make the public aware of these, and that one way or the other, the system will be broke, right? So if you do not have this, if you cannot make democratic decision making, then it will be chaos, which is happening in Brazil, right? Because like you said, you cannot deal with it because you have to appraise 90. So it's a waste of money in a way, because you appraise 90, you only have budget for 10. So, and then people can go to court, and then some will get it, some will not. So actually, this whole system is supporting inequity. So, and I think this is, I think, also the task of the HTA agency to bring this message across to the decision makers, or to those, I don't know. But that's the only thing that you can do. It's not your mandate. It's not your mandate to make the decision, but you can flag this normative, that these are all normative choices, right? So there is no solution for you as an HTA agency except to say, you know, by doing this, we actually, how you say that, keep the inequity, or maybe enhance the inequity even more than if you would have a system in which is more clear, you know, related to the needs. Because to be honest, I mean, maybe I'm now throwing something into the audience, but a lot of the new technologies, even though they are regulatory approved, the evidence of the regulatory approval is very weak. Then we provide public money, so we are going to do conditional, for example, reimbursement, also in the Netherlands. And then after 1 year, for example, or after 2 years or 5 years, when we do have collected more data, it appeared that a lot of these new technologies did not deliver on their promise. And this is our task as HTA agencies. We have to show that once we have given, the mark, okay, we are going to reimburse this maybe, and we negotiate price, whatever. But after 5 years, it has shown that this has delivered nothing. So we have paid 5 years in a row for nothing. And this is, I think, there are studies on this. You probably have seen this. There are colleagues who have evaluated, indeed, I don't know how many new active substance that were approved by oncology drugs that were approved by EMA, and how they actually delivered in practice. And this was almost none. And I can tell you the same for, the multiple myeloma. We did a disease model. So this is also something you can, model different drugs. In this case, we did, I think, 6 drugs, new drugs. We modeled them, or not we, I mean the HTA agency modeled them. And they assessed almost 60 different treatment regimens in this model. And only 2 of them were cost effective. And the rest, so the whole myeloma field in the Netherlands, I mean, I must admit, it's for patients that are not applicable for stem cell transplantation, so it's a sub-indication. But the whole myeloma field in the Netherlands is not cost effective. And this is hard to say, but it's true. So we are paying, for non-cost-effective drugs. And this is opportunity cost. So the opportunity costs need to be clear. And I'm not saying that I have the solution, but we need to be very clear that once we give 1 reais to this one, it means, and we don't know if this is not cost-effective care, it means that we keep, a financial unstable healthcare system in place. So these should be the messages. It's not only about, the technical aspects of this technology. It is about the consequences of this. So what does this mean? Because, like I said, we have the same problem in the Netherlands because, we already spent almost 12% of our GDP on health, but we have the same issues because we also I mean the workforce, we don't have the nurses, we don't have the medical doctors. It's huge. So and this component is only one component because the workforce is even more a problem for us. And then of course you need to think about how can we make the whole healthcare system sustainable in that respect. So we might need to, for example, focus more on prevention instead of all these new drugs. It's hard, but these are political choices to be made. It's not for the HCA, but it's for the politicians to make these choices. So I think you should also see this discussion in a, I think that's my answer. You need to see this question in a broader perspective of the financial sustainability or the sustainability in general of the Brazilian healthcare system, and not only the target of the HTA technologies itself, and try to focus more on that. I don't know if that helps you, but yeah. It's huge. Yeah, about the basic science. Yeah, that's a very interesting question. I mean, preclinical, of course, HCA most often comes into place phase 2, I would say, so not at a very early stage. But for example, what we do in our hospital itself is that we indeed work with developers of technology, but that's also already in the clinic. To see indeed how the potential, we call that very early HTA or value assessment, early value assessment, to see how the development of this new technology potentially can be shaped from the different perspectives in order to enhance the uptake in, say, real practice. Yeah, so preclinical, I wouldn't say there is a lot of HTA, but I think it's very important to already think about the potential societal value of your work, right? So you can think about this. And in our university, for example, we also give lectures about HTA already in the bachelor phases of also the basic sciences. So for example, also in the molecular sciences, we do give educational teaching. So this might be something to prone, I would say, basic scientists already about, the added value of your new discovery. Yeah. So that's more in the education than in the conduct, I would say. Thank you.
Pode mais duas perguntas?
More two questions? One more question. And then you can ask questions at the coffee break. Good morning, my name is Carlos Rezende. I work in the agency that is in charge of the supervision and regulation of the private sector in Brazil. We have an ethical dilemma at the origin because we work with the incorporation of technology for 25% of the population in Brazil, about that. And we've been seeking to bring the Validate Handbook to the discussion of the university where you work. One of the questions, because I'm a member of the appraisal committee, I've been seeing that most clinical trials don't bring the assessment of life quality. This has been being something really common. So this is a question. Shall we present for assessment for countries that don't have this demand, and then they go to the demanding countries? So this is my question. If in Netherlands there is this demand, and if this for an appraisal committee results in postponing the assessment and incorporation of this technology that many times postpones the assessment of life quality of these patients. Thank you.
sorry, if I understood your question correctly, you're asking that because randomized clinical trials often do not include quality of life data, that the appraisal committees postpone because there is no quality of life data. So no, that's not what's happening, at least not to my knowledge is happening, because we also include quality of life data in the dossier, so it's mandatory. So in our methodological guideline for cost effectiveness analysis, it's mandatory that the cost effectiveness analysis is based on utility, so the EQ5D. So we do have quality of life data. In addition to that, we also use in our decision framework, we use severity of disease as one component, and we trade off severity of disease that we calculate with proportional shortfall. This is also written in the manual. We trade off the severity of the disease with the cost effectiveness. So it means that the higher the burden of disease, of the severity of disease, because we calculate that at the individual level, patient level. So the higher the burden of disease, severity of disease, the higher the quality threshold. So we have 3 thresholds. So for say the diseases that have low severity of disease, the quality threshold is 20,000 euros per quality. For the moderate, which is moderate severity of disease, the threshold is 50,000 euros per quality, and for the very severe diseases, it is 80,000 euro cost per quality. And this is also written in the manual or in a policy document that shows to the society how we actually make these trade-offs. Of course, in addition to these 2 components, we also have the clinical effectiveness as a very important component in the deliberations. And we also have the possibility as the appraisal committee to also bring in other considerations. If, for example, very severe disease appeared not to be cost effective, does not meet the threshold, then we can say, okay, it's potentially not cost effective, and we recommend, often we recommend to have either pay for performance or financial negotiations with the industry, but only when it considers a very severe disease without, for example, no alternative. This is, for example, one argument that we use. And these arguments are also laid down in what we call kind of policy document, how we perceive these other considerations, because that also needs to be very transparent. And we might want to revisit this after a few years when we have more experience. But this is how we go about this. Yeah, I hope this is answering your question. Thank you.
Muito bom.
Very well. So now let's go to our coffee break. Let me tell you, I have never been in this room, this conference room before. This is room where we decide life and death of our university. It's University Council. It's so beautiful, this conference room. And thank you so much for the person who permitted us being here with this comfort and structure. And acknowledging the relevance of our discussion, this is why we are here. Thank you, everyone who made it possible, okay? Let's go to our coffee break.
A gente continua as perguntas e a...
We will continue the questions and conversations during our coffee break. We are going to share everything we need to know on precision oncology. I have only some minutes, but what I wish to tell you is that I would like to represent you, the audience, the population, on the questions you may have. I inverted what I was going to say because we need to understand the life cycle of technologies, how they have been behaving so far in a dominantly way, how they have been developed. What AGTA is something that has been growing in this environment, which is industrialization expansion from the 60s, the 70s in the pharma area, expansion of healthcare, and the AGTA genesis is part of this scenario. We have much more technology options, and these are choices that we need to make. This expansion of technologies, I will talk later about it. There's a phenomena, this is why we are here, a phenomena in the expansion and production of technologies. This started, its inception comes from genetics intensive development, genetics, proteinomics, a development of this frontier has been happening very intensely in the last 30, 20 years. And this area has been developing a lot. As has always happened in medicine, there's a scientific development in many areas, and there are impacts on medicine. And then genetics, genomics development has been impacted as well. And this discussion changed names over time, but there is a big production under different names. The most frequent names is personalized medicine or precision medicine. As it happens a lot, it has been happening. First of all, a higher production of studies and articles. It's translated in products into the market, but it happens later in a lower scale. This has always been happening regarding the entry of new knowledge in medicine and the science medicine uses as well. First of all, we have the research, doctors who are curious to try new things. And later, this is transformed into products. And this is what's going on here. So this event is always important, is also important, because in São Paulo there's a proposal to have technology development, product development of CAR T cells. And this happened in two instances, two organizations tied to University of São Paulo, one in Ribeirão Preto, where there is the Center of Research and Genomics, and another one in Butantan, where we are now. We need to understand what's going on, and we need to understand the frontier, this hurdle, to overcome this hurdle. We need to produce technologies in this area. This is what we wish. This discussion is presented, the production of knowledge, and this is also always done in a circular way. This circularity promises to have new developments, new knowledge that leads to research. They will get financed, and afterwards we have more development, more technology that goes to the productive sector. They are assessed, and finally, from item 4, we will have access and use of technology, financing and all. You have a number 5, item number 5. This is this figure comes from a paper in the National Academy of Medicine. They consider the item 5 as being very important. All these cycles, they mean learning as well, in a positive way. So this, radicalizing a bit, this is on a circle all the time, and we will have a nirvana, a complete happiness. Cycles are very interesting, but they oversimplify what happens into practice. Because in one of these points in this circle, something explodes and the circle is stopped. But it's interesting to use this kind of innovation life cycle and pay attention to the different phases they have. We have talked about the stakeholders, and I would like to tell you my opinion on them. She presented about them, but I would like to tell you, and you may not forget about the stakeholders. In the innovation life cycles, every country have their idiosyncrasy, their economy policies, and in the technological frontier, in cutting-edge research, only few countries have resources and technological domain in order to do so. A low-income country will not decide what we are doing. This doesn't happen. The resources for technological research and development, they are only in few places. This is an everlasting discussion in Brazil with its scientific and technological production incentives. We are considered a middle income country, and we can evolve to follow this technological frontier. We have been trying to be a producer, to be sustainable, and to make sense for our context, for the Brazilian context. Sometimes we talk about population, then we talk about individuals, and we talk about sick people. And these items are different. What's population? It's a diversity of collective with many different individuals. Population is not only the sum of its individuals. It transforms into a different concept. And sick people, they are a part of these individuals. In order to be sick, they depend of having access to technologies. And this is a condition that is created. It's not something natural that is the underlying since the person is born. We depend on the education process to form professionals, incentives to research, and industry in their innovation and production aspects, and in particularly the government and the regulation bodies. There's a discussion, and I would like you to think on every discussion we see here about the precision oncology, and I would like you to think on the stakeholders, where they are. I only have a little time, but I would like to tell you, this is a design on a model that is already established from the 70s on. This is how medicine is made, especially the chemistry-based model. This is the main system of making drugs, making medicine. And this is something important to pay attention. This is a continuing system. This system will not die because there's another system. This is a working system. There will be many productive systems existing at the same time. I'll go fast, I promise. I wish to tell you about the steps of research. The development of molecules. When we are looking for molecules, and today this has been stimulated by AI, artificial intelligence. So the research and development happens more separate from the industry. Sometimes startup companies do it, but normally it's more separated from the industry. Then the industry is the one being held accountable with the research system. And the industry is the main interested part. They have defined phases, and afterwards this goes to the regulatory system. So from this classical system, there are different instances of research, production, and development, and afterwards introduction of the medicine. They are relatively separated. So remember this when we are debating here. What are the relationship between the research, between the research centers and the industry? Who's responsible for the chemistry industry? The health systems in Brazil, this is a problem because we do not participate of great world clinical trials. We are commodities providers when we are talking about patients, then being proposers of great clinical trials. And what point in this life cycle these technologies become product of economic interest are submitted to the regulatory authorities, and when the medicine will be introduced to the market. This is an oversimplified paradigm of chemical production. It has been developed on an idea and thinking on profit. It was something developed to be used in massively. They are produced for everyone. For everyone is the same product. And precision medicine promises maximum customization. We will know our genomic base one day, and we could have things that are used by us in a customized way. These are the extremes. It's radical. It's something radical, but we have been showing this new form of production that seeks precision, customization, something that people didn't pay attention to before. In my opinion, I try to understand the following things: the position of population, individuals, and sick people in the life cycle of biomolecular technologies.
Completely different from the previous model. We start from genomic bases for molecular profiling, and even in the development of the technology, the patients are directly participating. The point is, the position of the individuals and sick people in this model is totally different from the previous models. For research centers and their impact on the production model, they are very much closer. The research centers with those who are in charge of the production and those who are in charge of the clinical trials, and how we are in this situation. At what moment they become an item for economic interest, and how do you have epidemiological supervision in this model? I don't intend to explain, and I don't know if we're going to have access to the presentations or PowerPoint later, to show the complexity on building databases for genetic profiling. It's not a simple item, it's not a simple activity. Here's one more discussion in that you have mentioned before. One thing is real world data for evidence of real world. This transit from one to the other, this shows how EMA sees that and the steps that it has to undergo. In growing complexity, we look at this and we have lots to learn. And in the document of those who are thinking of different innovation near to what
Esses ciclos precisa haver.
they are involving these models, and there must be imperatives so that we have equitative responsibility. We have to share responsibility with the stakeholders. We have to have incentives to have equitable decisions and learn how inequities happen throughout life cycles, and being in charge and being accountable for correcting them. We need guidelines, and therefore what Ouija has said and is going to say tomorrow is this immense change in how traditional stakeholders are positioning in this new situation, in this new era. Last year, we've had a study from the Association of HTA, the ATS, that says so that ATS, HTA say that we have to do not only the assessment in the incorporation, but also throughout the life cycle. We recommend it to happen throughout the life cycle. We know that there's uncertainty on evidence. When technology modifies throughout the life cycle, when there's a learning curve related to the use of that technology that takes to changes in the indication of the technology in medical practice. And when the healthcare services are impacted by the presence of this new technology, in my understanding, precision oncology is one of the technologies that have characteristics that recommend comprising ATS throughout the life cycle. I've passed my time. I'm sorry. Thank you. I'm really glad to call Professor. I couldn't hear the name because she's out of the microphone. Sorry. She's out of the microphone. I'm sorry. Okay. To aggregate. Okay, Professor Roger Chamas. to to face new situations, new challenges. It's been a while. We've been talking about this, and now it's happening. So I'm really glad to having him here today. Good morning, everyone. It's a pleasure being here. Thank you, Patricia and Maria, for this opportunity. As Maria has said, my name is Roger. I'm a professor here at the medical school. I've been working in oncology, and I've been challenged by Patricia and Maria to look differently to an issue that we've been facing in our area. I'm really happy to see here I can identify some people that have been together with us throughout this journey in chemistry, in information technology, postgraduate student, Biomedical Studies Institute colleagues, stakeholders who are businessmen, doctors. This is the environment we have to promote, Patricia Maria, to discuss mostly the human resource education or training that are going to be on the front line in research for these advancements that we've been watching, both in the production of new molecules and the understanding of the roles of molecules that we have as predictors for answers or any other things in the medical area, and instruments so that we can have therapies that have more precision. This movement, I know that you've been following the literature in the sense, starts the promise of the Human Genome Project is that when it was concluded in the 20,000, they summarized everything we are. And together, all of us humans, together with that scratch, we learned that after we knew what we were, we would have the conditions to eventually treat and prevent diseases better. Many things that genomics has promised, and somehow it couldn't deliver, at least not in the sense in which was originally presented. So we know who we are, what we are, but we don't know yet, and I think we are far away from that, to unveil this, to have to get to know how we work or in normality and abnormal situations, in afflicting situations that are the diseases. We have a mindset that is quite pathocentric. We are always seeking diseases. We learn a lot from this. Fisher, who was a sanitary doctor, he got to be known not only as a pathologist who was a sanitarist, but mostly because he was a pathologist. And that's the ambiguity, because the prevention of the disease and promotion of health that determine most of the activities of some of our patterns. But since the end of the 19th century to today, what unites us is this pathocentric view of life. So we have to challenge it and change it. More than that, we have to be thinking of training people so that they learn the consequences of their discoveries and how these discoveries or findings are going to be applied for a social benefit. We've been seeking to discuss in the university for a while the impact of everything we do. And we know how to measure well the scientific impact, or at least we think we know, but we have to go beyond. We have to think of social impact of what we do, and also economic impact. And this is what the society has been demanding from us. We have to organize ourselves to seek to deliver to the society what the society expects from us whilst we're São Paulo State University or the academia as a whole. With this objective and not another, our director, Carlos Carlotti Jr., suggested at the beginning of his mandate for us to think differently, to form transdisciplinary centers so that we could have somehow preparing the professors and post-graduation students to answer rapidly to these demands. A little bit of that happened as a response of the pandemic, coronavirus pandemic. But somehow, throughout the pandemic, we learned the university has a lot of competence that is being installed, and when it's required, it could organize promptly and deliver things that had great effect on the society. In this sense, the dean challenged us to present proposals that could allow the organization of transdisciplinary groups to present solutions and make up groups who are critically prepared for the challenges that are put ahead. You probably know we have 2 centers in agriculture, one in Amazonia Studies, another one in institutional organizations, Brazilian organizations, one center in AI, another in greenhouse effect gas emission, and the one in health, that is the Oncology, Precision Oncology Center. This one is called the Convergent Center of Studies for Technology. And this is the result of a discussion that was so interesting. We had with colleagues from the Chemistry Institute and Pharmacy and Biomedical Centers, Bioscience, VET in São Paulo, colleagues of Physics Institute in São Carlos and the Medical School in Ribeirão Preto and ESALC in Piracicaba. We've organized these study centers of converging technologies for precision technologies. We hope that this can be a complete center, a comprehensive center of oncology, that we have this futuristic acronym C2PO. It seems a Star Wars acronym. So the idea is that we have this technology studies for precision oncology to start articulating solutions for problems that were being posed by the society. So what we want to study is the precision oncology area as being one of the areas of medical precision medicine. Why oncology? And what challenges we have? We seek to increase the diagnostic precision and in the indication of treatments to try to deliver the best treatment possible at the right moment for the right patient. This is the aim of precision oncology. And our biggest challenge is to have in the public sector, in the public service. Actually, the challenges are huge and will not rely only on the university. We're going to need necessarily to articulate as decision maker, policy makers. We are seeking to interact with all the stakeholders to conduct this activity to the end. And more than that, we are seeking to use this center as a plan for training for PhD, postgraduate students to act in a different way in the formulation of the problems. This is our objective. So when I heard Maria saying that most people, things that most people in the medical school look at medical school in biomedical and biochemical and pharmaceutical areas, they don't hear usually. So start listening to this. It's something that we have to do so that when we are formulating questions that we are going to put, and in the moment of our formation continually, we are going to have this variable. This variable has to be tackled so that we are not training for another silo. We don't have to improve the density of our silos. We have to integrate our competences. That doesn't mean that we are going to be careless about our disciplinary background. We have to be deep in what we do, but we have to be connected on the demands and how the partners are acting. In my opinion, this is the main learning I've been having over the last months, because I've had the opportunity of acting in the creation of C2PO. The problem we're going to see is cancer. Why? Because of the numbers. We have expectation of 600,000 new cases in 2023 to 25. And countries like ours and many countries of the global south, our estimates are that we're going to have an increase of 70% of these numbers up to 2050. So the expectation is that we have more than 20 million cases by year until 2050. This is our reality, is that cancer will be more frequent.
On one hand, what happens in the countries from the global north? These numbers have been scaring people. But the control ratio of cancer in the north, global north, is much higher than in the global south. Here, unfortunately, we are surprised to see people dying more with womb cancer in 2024. Or they have an increase in the mortality of subjects with breast cancer in our region. The womb cancer in 2024 with the HPV vaccine. This has been increasing. It's frustrating, so frustrating. We have been failing in educating our population. We have been missing something. We need to change our position. This on a more global point of view. Thinking on biology, biological problems, our society will have a great burden in the future. On problem, cancers have some features that are very different from the features people with cardiovascular problems have, or other areas of medicine where precision have been increasing. Mental health will be a big problem by 2050. Heart diseases will continue being great problems. Cancer probably will be the #1 cause of mortality worldwide by 2050. Cancer is, the problem is we only use one word to classify hundreds of diseases. Behavior and the answer, how the patient behaves on its treatment can vary hugely considering different groups of people. Different people with the same cancer will not respond the same way. And by genetic nature of cancer, cancer is a disease that evolves. This characteristic of the disease we study. You may think, other diseases also evolve. Yes, that's true. The other diseases progress, but cancer evolution ends up being featured in a genetic or epigenetic way. They are different diseases. This is a beautiful paper published 10 years ago. This paper shows and highlights something that was anticipated, that was definitely proved. The different lesions a patient has along their life from a kind of cancer and their metastases. Genetically speaking, structurally speaking, this is different. So it's heterogenic in the same individual. So cancer is not only one disease. There are many genetic, epigenetic diseases. The disease changes. If you like the idea to have cancer as a target that we're trying to avoid. And this is a very frequent metaphor. This target is a mobile target on the genetic point of view. There's something clear in literature today. Changes pile up as time passes by. In this line, I'm highlighting there are genetic changes. It doesn't important the detail. There are genetic changes. Up to a point, what would be the primary tumor, the tumor located in the place, in the origin organ of the cancer, they will have genetic diversity. You see here different branches. There are differences. As if they were different genetic diseases, and metastasis will go different. It's another disease. And what we are doing up to today, we have been treating this disease, we have been treating the patient. We do not treat disease. We treat the patient based on the primary cancer. Even if we show there are molecular differences that make metastasis different from the primary tumor, we tend to treat the patient with the information we have from the primary tumor. Eventually, this will be efficient to treat this part, but not that other part. And this may be one of the reasons that we will flaw. We will make a mistake. This was a first paper, but this notion is extremely replicated in literature. What we have been treating. Eventually, Professor Pilar will talk about it further. We may use this molecular information to spot specific ways to treat these diseases. 2 years ago, this molecule VHL that I show here, this molecule, it's an important conducer of this genic change in the renal cancer that is being metastasized for the lungs. This was one of the key molecules studied by Kellen. He received a Nobel Prize for their studies. They could develop a molecule that has been progressing on clinical trials to control specifically the diseases that are dependent of these specific changes of this molecule. I do not want to provide more details. It was as if we would cut the tumor by its roots or by its trunk. So it's a branch, a tree. We have a change in its trunk, and there's a molecule in clinical protocol in order to control this change. This is the perspective we have in the scientific area. And this is highlighting the need to have more precision in the treatments. Similarly, what do the research tell us? If the disease evolves, we need to have more precise diagnosis. And they need to happen in real time. We need to track the patients in their journey. And we need to assess, in a way, the presence of tumoral cells, tumoral masses, wherever they are. So literature has been developing a lot. There are many clinical trials in order to define the liquid biopsy. We needed to see the amount of tumor in a patient from biological fluids as saliva, urine, and so on and so forth. The idea is to design these evolution trees, the tumor evolution trees, and I need to understand how these trees are being trimmed by the treatments along the evolution. It's a way to understand the evolution of the tumor and use methods that are more efficient. There's the possibility of imaging real-time methods. It's more and more frequent to see new opportunities to map, for example, metastases about prostate cancer by using specific markers. And when these specific markers are used with positron issuers, they can be used in imaging studies as a PET-CT, and we can track the evolution of efficient treatment when we are losing the positive masses with this positron marker. We use this positron marker a lot. Technology has been developed so that We can not only diagnose the disease, but also treat it. And we can treat it then by ion. This peptide that is being expressed here in prostate cancer metastasis, they may carry a radio drug that would work on the tumor mass. So we use the diagnosis and the therapy at the same time. So this is theranostics principle. And we can use the immuno system, which is an evolving system for treatment. And this will be approached by Wanderson in the afternoon. He will talk about the CAR T cells use. This is an overview of what precision oncology may do. Diagnose better, treat better. Diagnose in real time. We need to do so, but there's a cost allied to this, and we need to develop the research and try to understand how we can do it in a socially responsible way, with equity. Possibly to have less inequality in the healthcare system, and this is a huge challenge. We do not have a solution. We have a framework for several solutions, and this framework is the strategy to have the 2 specialized centers to treat cancer from University of São Paulo Cancer Institute, and an oncology center from the medical school from Ribeirão Preto in São Paulo. They would be hubs to interact with community. So all of you are invited to interact with our centers, ICESP and the Oncology Center of Ribeirão Preto Medical School as well. In Ribeirão Preto, Leandro Colli is the coordinator. Here at ICESP, I am the coordinator of our center. We have a board, a managing board. I do not see any other colleague from the board. But the idea is to organize a community from USP, University of São Paulo, in order to coordinate and articulate proposals of projects that would help us achieve our goals, which is to identify, research, and develop progressively in a more precise way in order to diagnose and treat cancer, seeking for subsides so that the policymakers would be able to work. We are not policymakers. We are part of the academia, but we need to provide subsides. We need to subsidize policymakers in order they can develop the laws. We have a double view. We wish to have a Latin American reference in oncology in order to develop and deploy the innovative ways to diagnose and treat cancer. We wish to be a communication and education center. So we produce new researchers, entrepreneurs in this area. This is our objective, our goal. Our values, they are University of São Paulo values. We wish to organize in order to increase our South leadership as a strategy for international interactions with the North leadership. We wanted to have 3-party interactions, South-North. So we wish to do this with Latin American countries. This is why we wish to be a reference here, and also the Portuguese-speaking countries in Africa. And we are completely interested in have more partnerships, especially with Angola, because of the Bantu ethnicity that is so important in the formation of the Brazilian people. So this is the structure that we have in order to have different studies done that go from the genetic basis until the clinical consequences of our activities. In this background, we have an opportunity. We have been developing it in the last 2 years. We are using what we have here in our Convergent Center for Precision Oncology. Do you see here a bigger oval figure? All of this is our C2PO. We have a lab, which is ICESP lab. We have clinical trials, clinical research that have happen here in Ribeirão Preto. Intertwined, we have a biobank that will enable many of you to organize cohort studies for different testings. And from the fellows that are interested in data science, biobank has a big set of data. They are clinical data from patients, and they need to be explored more and more. We have colleagues from the different campi in the University of São Paulo. There are different facilities being organized, the metabolomics and proteomics in Piracicaba in São Paulo, an advanced cell therapy facility, which is the Advanced Therapy Center in Ribeirão Preto, another in São Paulo, which is near the University Hospital. And we expect to have the production of CAR T cells for therapy. This is one example, it's not the only one existing. The Center for Translational Research in Oncology, they have the support of the Science, Innovation, Science and Technological Ministry. And they wish to be the center of an international center for genetic engineering and technology. This will permit to have more interaction with different companies, public or private. We have a crescent interaction with public companies, Butantan and Fiocruz. And we are interested in having more interaction with private companies, and I see some candidates among the people we have here in our audience. If we succeed, and this is not a truth, if we will still have a governance with the Ministry of Science, Technology and Innovation, with our Provost of Research and Innovation of the University of São Paulo, the President of the Academic Health Center of University of São Paulo, a representative of Fiesp, and another one of Cabio, which is a center that will be based in ICESP.
To increase the interaction with companies, to offer different strategies, to test possibilities to improve the precision oncology. Our operational strategy is on the articulation of projects. We seek to talk to different researchers to organize the different projects. They have a vast range of projects. It's very interesting to see the possibilities, the various mindsets, and the different elaborations that we are seeking to put in the context of research in oncology. Is it going to be put in practice now in patients? No. But getting closer to the groups can impact on the way we design the projects. And this can be accelerating somehow the transference. And this is what we believe. And more than that, we want to do this with the eyes of the economists and specialists that are going to assess the technologies to be applied in order to instrumentalize the researcher to do more and better. So this is going to be a new approach to regulations and public areas. We have more examples. In the afternoon, we're going to have the CAR-T cell-T, which are one of the examples. We have been participating in different genomic projects that are supported by AI. Many projects of markers associated to AI, plus the possibility of developing new molecules with specific therapeutic results that are going to be shown by our clinic. So this is the vision, and I hope we have more opportunities, Patricia, Maria, and the participation of your group is key so that we can subsidize these opportunities. The challenges are huge, but our will is even bigger. Bigger than that, only our detachment of mistakes. If we make a mistake, we can start over. So I would like to leave our address, c2po.usp.br. Thanks to Lucas Youssef, who is our administrative analyst, who is here at the back of the room. Lucas, would you raise your hand? He can help out with for those who are interested. And he can go after this website. And he is the head behind the website. Thank you. Thank you, Roger. I would like to invite you to the table. And I would like to call our moderator. Please, you can go to our moderator is Professor Maria del Pilar Esteves Diz. It's an honor being here, surrounded by these amazing professors. Professor Maria, I started understanding the assessment of technology since we started in the death commission at a clinic hospital, the HC, in a remote past. I say that because for a commission that was ordinary, it has raised that discussion that the name was wrong. We had to think of information systems in the complex, and the change of the commission was the analysis of information on the patient. At that time, we had no information technology. It was not systematized. And the commission started to see that before the hospital started implementing this in their everyday work. This is an example on how you bring the theoretical knowledge to the practical world. And we can start to see the future with other perspectives. And Professor Roger from C2PO has the ability to transform our everyday lives. Both should see one another. A clinical needs to see the basic area, and the basic service has to look at clinics so that we are productive, more productive in the development of technologies. I don't know how long we have got. Patricia, how long do you give us? How many minutes? 20 minutes. Okay, so I'm going to open for questions, and then after the questions, I'm going to ask some. Firstly, I would like to thank for this event and the organizers, congratulate you and congratulate Roger and his team for the creation of the center. And I have two questions. First is, if the question, when we think of precision medicine, how much it is more realistic today, thinking of the global north, compared to ours, for a matter of late diagnosis, and how much we lose of our ability of doing precision medicine for late diagnosis. As it has been demonstrated, we have subtypes of metastasis. So how can we think on reducing this time of diagnosis for the population? And the other question is, wouldn't it be worth to incorporate some mechanisms that are simple and cheap to try to design a little more that patient? For example, physical activities through questionnaires and surveys, the quality of sleeping quality, because this can have answers in immunotherapy. So how can we implement cheap tools to direct a little more the subject? We know that molecular would be the best, but we know that there's a budget restriction and constraint on that. Thank you, Zeca. Professor José Carlos, I'm sorry. You are right. First, it's a hypothesis that should be tested. In what moment we still can be precise, mostly with localized tumors, but very extensive. Perhaps they accumulate a diversity of alterations that even when we know what profile it has, the impact it's going to have on the patient is zero. Also because we are seeking molecular alterations, but we are seeking only the action, the activatable molecules. And in the public sector, these opportunities are very small. It's a very restrict number of treatments associated to that. So when we think of precision, we need to seek markers that maybe are not the data of the molecular that are going to impact on the conduct. But we have to be more aware of that and have more studies in partnership with the private initiative, in which we have another reality compared to the public system, and try to identify if the size of the tumor is a variable that has a way and discriminate more than the variable of molecule itself. This would be an example. We can be precise in different ways. So what we seek and what we need with the molecular information is that we can be good with a reanalyzation of morphological analysis of the pathology, a re-examining of the imaging, screening exams. We have no eyes to identify the meaning of the variable. But with AI, we can seek to find a set of variables that are going to discriminate some things that we haven't learned how to look at, or things such as the ones that you are suggesting. What we have to generate is actually the evidence. So before implementing something like that in the routine of the hospital and use this information, we have to have solid evidence that this is impacting and this is going to change the conduct. But I'll let Pilar comment on that. I think these are relevant questions. The target is actually, this has been designed to the target. We work with advanced neoplasias. Patients who have a progress history and they had a starting diagnosis and evolved very quickly. So they come with the late stages of their cancer, and we have to work on their survival before the possibility of their treatment. So this is something that the liquid biopsy is going to help with some moments. One of the questions, though, in your questions is that the construction of the real-world evidence, because clinical studies are a little pragmatic. They are the set of patients is very uniform, are very homogeneous. So to have an internal possibility of the study, I need a multiform set. Hypertension, malnutrition, basal malnutrition. This is a factor that affects the results of our treatments. So these studies of the real world could bring to us the real benefit of this treatment for our population, mostly for the population we have in our unified health system, which are most of the patients with cancer. These studies are not cheap. So we needed to put together university and public sector to develop these studies and having a big amount of information in a short space of time so that they could deliver what they were supposed to deliver or they promised to deliver, because it takes a while for us to see the results of these studies as positive and negative. ESMO this year has shown negative studies, and I've been trying to understand why they were negative. But this is affecting oncology. The phase 2 study is very promising, phase 1 very good with AI, that we find the targets very quickly. They are very promising. And then on the third phase, it is negative or useless. So bringing this to reality is by fomenting studies of the real world. But the academia can't do this by itself. We need the actions for various centers. This articulation is a must, so that we have clinical data in this structure where the benefit is.
Thank you. I really like what you said, especially with regard to negative studies. I think it's fundamental that we publish these negative studies. But we also do know that this is often, not very easy to publish negative studies. So also within the research community and in the, the publishing world, I think there needs to be more openness to publishing negative study, because indeed what you're saying, they can also help us to understand a lot of, the failures. That is very important. So in order to move also the science forward, it's not only the science as such, but also the openness of fair data, right? So I think that's very, very important. So the educational, or not the educational, the research community also need to be more open to publishing the negative studies. So thank you for raising that. Thank you. Very important point, I think.
As Pilar reminded us, in my existence in the 90s of not having information systems, in my lectures, I feel sometimes a little tiring. I know that people think I'm boring on saying how the health system is forgotten in these scenarios in terms of producing information systems to be part of the routine, because these information systems are seen as bothering the noble role of the doctor, that is identifying and treatment. So it's a priority face to the patient, of course. But with the resources that we have, we need to improve the possibility of creating data that are becoming information and evidence. And this requires a policy of introduction of data and information that can be part of this service and the managers. Of course, we have improved with our platforms. MV at the clinical hospital of USP. Everybody says that everywhere you have electronic charts, but the electronic chart is working to register the evolutions and send to the pharmaceutical sector, but the platform has not been added with the results. The tables and charts are not available to us in the system. So we haven't purchased this module of charting and the tables. Of course, there is this. We can do it. So to step ahead on that, so that it's an objective shared by everyone, we have to understand that this cannot be crafted and handmade. And we're going to have smaller precision. So thinking of my elderness, I've participated in other systems that are no longer existing. It was a huge work led by Laurentio Professor. So many trainings, investment in the services for archiving for the hospital, the clinic hospital of USP. It's being implemented, the CD11. The ICD-11 is in process. It's being implemented, no longer on a paper, but electronically. And I was there at the beginning when it was being implemented on paper. Does it impact in our diagnosis? How are we going to produce this? Statistics, comparable statistics. This is not being discussed.
So this discussion of information is something that doesn't interest many people. And there's a feeling that computing has resolved everything. No, it hasn't. Because we need processes, flows, standardization. As Lígia has already said, we need agreements. So ICESP needs to lead such a thing. If we mean to evolve in precision oncology, this is basic. I'm sorry for saying so much. We have been on a crusade. We have some partners in the Ministry of Health. We have been trying to have a greater protagonism from the Ministry of Health in designing clinical protocols that interest our unified health system, SUS. In our center, we can't use patients from SUS, the Unified Health System, for clinical trials. SUS do not pay for their patients to participate in clinical trials. We need to find external patients to do so. So we need to be named partners with the Ministry of Health in order to have these patients participating in clinical trials. Every change of governments, we tried this, but we weren't successful so far. This is a question that I was going to ask you. I read a paper recently. They discussed how we can have this interface made with the governments and the private sector in order to implement research. And one of the proposals was to have universal sequencing of patients, and the government would pay for it. So we had a huge database of targets and then triggered the research. But we are way before that. We can't develop researches time we are going to use therapies and the drugs used. This is something of public interest. Even if we find the drug, we can't use the public health system patients for that. So it's a political matter that needs to be discussed. Yes, it's a political matter. And first, we will have the genome being done because there are forces. And there's a huge influence from the market to have access for these pieces of information. We are not going to have this partnership with the Ministry of Health. We won't be able to scale the treatment. Well, this is a game. We have 4 people. Can we have the 4 questions asked at once? Yes, sure. Short questions, fast answers, okay? Please.
Boa tarde. Queria agradecer vocês pelo...
Thank you so much for the event. As a representative of a startup working with oncology, it's such a pleasure and such a huge responsibility to hear from you on the knowledge, care, and responsibility we have. We need this expertise in this long cycle of building frameworks in public health. On this note, I would like to provide food for thought. I understand the limitations. An agreement is a nice word on the level of compromise we need in the system, broadly speaking. We understand the mutations of government, universities, and the private sector as well. How can we articulate how universities can do this with the private sector and the startups? Because they have a stronger technological background. How can we get united in a responsibilities framework to build evidence that will subsidize innovation conjointly? I don't see this going on. I only see this happening among startups. Problems haven't been solved. And this world, the university is separate from these excellent hubs in computing, for example. And the startups do not have a responsible debate to debate cancer. How can universe get closer with the private sector if how can we have this more harmonic debate and some efforts if the pieces of the system are not together? We have the innovation centers here and AGC in Ribeirão Preto. We also have innovation hubs there. I'm not sure if Supera has been incorporating AI now. But as an institution, we are looking for proposals of co-development, and we are completely open to do so tomorrow. You are invited for tomorrow's session. Good morning, I'm Alessandro. I'm from ICESP as well. I work with Professor Chamas. This was already answered. The predictive power is big. I was going to work with real world research, and this is well received. I mean, I changed my question. How are we going to finance it? Professor Roger talked about the partnerships. But let me make a comment. Professor Chamas' speech reminded me of something. In geriatrics, there is a big difficulty, which is multimorbidity in patients. We are going to test something for a patient, an initial condition, but they have diabetes, and there's a medication that improves these, but gets psychiatry worse, psychosis worse. So it's a dilemma that industry ends up not selecting this kind of patient. They want to have a hegemonized sample, but there is a evolution paradigm of oncologic disease. There is a multi-morbidity. And how can we escape from this multi-morbidity if we're talking about cancer? And there is something else that when we work with multi-morbidity, we need to work with. In a real world, this model would be easier to be worked with. My question is, if we invest in these kinds of modeling, would this make easier in the analysis of cost effectiveness if this is well accepted in the community? Partially, the professor has already answered. I can only tell you this is not well accepted in the community. This is education work that has been done with the medical and patient communities. These are studies that are valued. This is an emotional problem. It goes against people's expectation because in practical life it's not as good as it seemed before. I would like to consider some things regarding what you talked about. We find out patients in the unified health system, and we will live with it for some decades. We need to find patients in advanced stages, and we have problems with screening in cancer. We do not screen organized. And about precocious cancer, precocious early diagnosis. We need to improve it in parallel. We need to improve our molecular biology tests and look for new therapeutic targets. This difficulty will coexist for us and other emerging countries, but we are a huge country and we have different reality in every region of our country. Regarding new therapies and how they perform in the real world, monitoring incorporation, we discuss it in the ATS framework. We need to observe carefully. There are many antibodies that are so expensive. We are not sure if they perform well. As a CAR T cell, they are not one shot. If I prescribe many shots of this medicine, it will be so expensive. We need to pay attention how we are going to deal with it with real world evidence, even if we do not have natural language processing tools. Today we cannot structure data so that we have reports in an old school manner. We can't do that because everything is lost in clinical notes. So they are a text, a big test. We need a tool to plug there. Even old school, there's a way out, and it will be cheaper. And another point, regarding immunotherapy, there are some studies that show the initial doses in milligram per kilo. And then there were many other fixed doses. Our women, I'm smaller than an average American woman. I'm taller and skinnier. Should the dose be the same? What if we get the milligram per kilo doses? How many patients would we treat before the fixed doses? For the industry, that has been profitable to fix some immunotherapy doses, especially for some drugs that seem to be something that treats many kind of cancers, rheumatological diseases, and the pieces of information, they are endless. The fact sheets are endless. We need to think how we can do this ethically. How many people would you treat? Maybe if it were a more rational dose, would we include this in our health system, public health system? It's perfect what you have just said, all of your arguments. Now, Fiocruz with the biosimilar plant, they need to propose new clinical trials that would investigate what you mentioned. Similarly, what you are mentioning, they are great research opportunities. And we can find different ways to deliver the payload for treatment. You are thinking as the precision oncology researcher on a country like ours. If I could hire you, I would. Professor Marianne is asking where you are. You didn't present yourself. I'm from UC Camargo, a value office. There are two arms. ATS is one of them. The other one is agreements with industries and insurance, health insurance to see cost and quality. CAC Camargo is an entity associated to University of São Paulo. Maybe I can hire you. There is a problem when we talk about dose administration. If you are not used to it, this was conducted also always in the maximum tolerated dose, and this is not applicable for target drugs. We need to review the model of dosage. We need to go back to the bench to work better. There are Indian studies that show that doses 50% less than the standard work. They come from a country where the academia isn't respected as producer of high-level science. But we need to review that to make it feasible to study this dosage. We need to use with the efficient dosage, not the maximum tolerated one. This should be considered. Our last question. People talk a lot about incorporating genetics in the clinical trials. What do you think about it? Have you thought of it for Brazil? Carolina, we should look for that responsibly to bring, to incorporate genetic information in clinical trials. This is your question, right? We should look for doing so, but we need more pieces of information from the basic research area in order to translate it for the clinical protocols. Without a doubt, you need to present yourself. I'm Bonilla from the Preventive Medicine Department. You are in our group, all right? Yeah, I'm the top. You are already invited. Our colleague from AC Camargo, you are invited to take part. Let me finalize the session. I'm so happy. Roger, when you say Maria and I provoke you, this is a compliment for me. When we provoke you intellectually speaking. In this event, technological innovation of precision medicine. And this is also a provocation for other people. This assessment for the life cycle, this is not only after Anvisa and Conitec. We are provoking this group. A colleague asked about nanotechnology. Can we have an early technology assessment done? This kind of technology need assessment along the cycle, not only for its incorporation. Here in this event, we could have the possibility to have many stakeholders included for discussion. Technology, innovation of precision medicine, and we need to think on the ATS model that we have been using and working here in the country. So it's food for thought for every side, not only precision medicine, but for us from the ATS arm. So it's very good, but we need to stop for lunch. And we count with your punctuality at 2 p.m. to come back. Thank you so much.
also patient-centered decisions. And we have to consider as well logistics and organizational issues as well as sustainability. Another support for Conitec are the NATS, the Health Technology Centers. Today we have 119 NATS within the network, and they represent all the regions of Brazil. And many of these NATS have a partnership with the Ministry of Health to elaborate protocols and guidelines, therapeutic guidelines, methodologies to standardize methods of HTA studies. They help us out in the analysis of recommendations and also in the elaboration of HTAs to be or not incorporated. Oncology imposes challenges, other challenges. Some of them are here. In the next slides, I'm going to drop them down so that we can see better expanding. High prices with uncertain benefits, cost effectiveness, finance model, decentralized execution, access in regions and hospitals, and insufficient infrastructure for molecular and genomic tests. All these are the background of oncology as challenges for SUS and for Conitec. First of all, decisions on uncertain benefit. In this study, we have evaluated 65 oncologic cases. We evaluated the price and the magnitude of benefits of the medications. Some were registered in the United States and Europe. And what we can see in this graph is that the drugs that present high clinical benefit, both and low benefit, clinic benefits, they are the same price. So that doesn't follow the magnitude of the benefit. Another one has evaluated oncological medications approved by the European agency. We see that the yellow and green bars are the ones that present more beneficial benefit, and they don't represent 40% of the approved medication. On the graph to the right, the income of the companies that deter the register and the patent, their income, their revenue does not change no matter what benefit they give to the patient as a whole. So we have a challenge that many medications are being registered with at high prices, and these prices are not related to the benefit. In Brazil, this is even more difficult because our entry price is so high. Some oncological medicines had their prices defined by CMED, which is the Chamber of Medication Management. This chamber adopts a mix of other countries as an average to decide on the price. The dot that represents Brazil is the red one. It's among the highest prices, far above from other countries, such as Canada, France. Many times it's just behind the North American market, where the patent has been registered. So we see a movement of FDA registration, then after in Brazil to keep the pattern of prices. But this is incompatible with our payment capability. If we see the treatment by therapeutic class, this follows. You see the red dot that is representing Brazil is at the limit, the upper part of this distribution. How can we do this comparison of cost and effectiveness through an economic point of view. Brazil has defined a threshold of pricing 35,000 by years of gained life, and the quality is 40,000 per quali. That's associating quality of life with the gains. We have the measure by quali as a preference for decision making to valorize the experience of the patient with the technology. But it's important to highlight that this threshold is not a limit, is not a parameter for decision making. It's one of the criteria that are analyzed by Conitec. Besides, some modifiers are observed to this amount. This can be multiplied by 3 in some cases that have been pre-decided together with the threshold. For example, in rare diseases, diseases for children, and serious diseases. In the use of oncology, we would have these positive modifiers to increase the number of the threshold, also in endemic diseases for low-income populations. Even when technology is considered cost-effective, there are modifiers as well. So it's not a guarantee that this is going to be incorporated. If it's cost-effective, but there are uncertainties on its efficacy or safety, or if there are some issues about logistics, and it's not possible to make viable this incorporation, or if it is a budget impact that is prohibiting and committing the sustainability of the system, then it's going to be stopped. The funding of SUS is tripartites: government, state, and cities. So far, we have this model of finance. We have a repay for fixed value by the union, and we have a counterparty from states and municipalities depending on their capacity of payment and prioritization and needs of each territory. And it's mostly decentralized, being held by centers and oncology services by states and cities, but most of them are not held by the Ministry of Health, because there's a big challenge on that. Because when Conitec approves that, the price that has been proposed in the incorporation, we understand this price is going to be the practical price. But today we don't see that, and it's a present discussion because there are no laws to oblige them to keep the price. So this is a discussion we've been holding in the Ministry of Health. The decentralized execution has been thought by considering what Professor said this morning. I'm going to drink some water, excuse me. At oncology, all these specialties of oncology make desirable a better autonomy, both in services and clinical agents, depending on the need of the patients in that certain center and the expertise of the people who work there as well. So this is the defense regarding this model. But what we see is that the distribution of these unities that serve at SUS, it's unequal in all among territories in Brazil, and the capacity for payment is different. So the more pulverized, the less capacity for payment. So even though this justification that makes no sense, that oncology is a peculiar case, what we see is that there's huge inequity regarding oncological health in Brazil.
I would like to show you an example of treatments that are available in SUS after this incorporation. This is part of the coordination I'm under currently, and we wish to see how much has been delivered by these treatments if what we were incorporating is put into practice. For example, medicine incorporated in 2013, not recent. We have been discussing it at Conitec for quite a lot. This medicine went to small cell lung cancer. First of all, we considered the procedures authorized in oncology where this medicine would be used. The procedure is not specific by medicine. This autonomy is already seen. We would like to identify how many processes were accomplished with this medicine. And we saw a higher use of gefitinib compared to the other one. The one that were more used, gefitinib, it took 4 years so that the number of patients that would receive that therapy would receive it. So diffusion and access is much lower. It's much slower than we imagined. So we imagined we were having real-world studies in technology, and now we are worried in verifying the access and the process to implement these technologies. If we assess erlotinib, which is the less used, now we haven't reached the number of patients that would potentially benefited by using this medicine in SUS, in our health system. So first of all, we paid attention to its price. Per year, the lower price in bidding, public bidding, from 2014 on. We see that gefitinib's price is lower than erlotinib. The gefitinib's price is lower than erlotinib, and price compared to the SS. So the other institutions' part will be much higher if the health service would like to use erlotinib. As for this new scenario, last December had the new national policy to prevent and control cancer that was on from this year on. This law has been implemented the current year. About acquisition and access, cases are estimated where the centralized buying of the medicine by the Ministry of Health would be preferable. And this would happen for high complexity treatment or higher incidence of neoplasias, or if they had a higher financial impact. Bringing this for the federal circles, we would have a possibility to negotiate price and reduce cost. Even with a decentralized buying, this procedure will be exclusive for the incorporated treatment. In some cases, the APAC value exceeds the treatment and they do not offer the best treatment. So we have this exclusive APAC for the incorporated treatment. And then the objective by incorporating technology is to have a more precise and less invasive technology. The bill reaffirmed the use of AGTA and economic assessment being provided by Conitec, and the deadline of 180 days to have the offer of the incorporated technologies. So we verified the need to monitor the access, performance, and use of this medicine. We had a partnership this year with the Institute of Social Medicine of the University of the State of Rio de Janeiro. We need to identify the factors that contribute for the heterogeneity of oncological attention in the unified health system in Brazil. We need to see how equitable this access is. We need to distribute it by geography, race, age, and gender of patients. And then we need to improve the decision-making process in oncology technologies. And there's another improvement by the Ministry of the Health, which is this national program of genomics and precision health in Brazil called Genomas. The objective is to establish the health basis of precision health in Brazil and implement it in our unified health system. We wish to create a genomic national database to foster the national industry and to strengthen our unified health system by training the workforce. And in genomic sequencing, the objective of the program is to improve diagnosis and risk predictions, personalized treatment based on the patient genetic profile, and include sub-represented populational group for more effective treatments. Our participation is meant to identify how we can improve in order to benefit more people. I'm at your disposal. Thank you so much.
Obrigada, Carol.
Thank you, Carol. Carol talked about Conitec's perspective on precision medicine, the perspective of Conitec. Now I invite Dr. Aliton to talk about the perspective of a person that is a center of ATS. He provides the assessment of ATS, and he has been one for quite some time. We will have the privilege to see the perspective of an assessor, a person that has been carrying out this kind of studies, and a person that is involved in training these professionals in ATS in Brazil.
Doutora Patrícia, obrigado pelo convite.
Thank you, Professor Patricia. Thank you for the invite. And I had to study in order to have this presentation done. I'm not a specialist in genetics, although I'm a specialist in ATS. As I told you in the event we were last week, when we are together in these events, we see that Rebrats has been working. We can have capillarity with our centers of HTA. Now let me show my presentation. Today I'm Social Responsibility Director in Oswaldo Cruz Hospital. I'm responsible for the project portfolio we have for our Unified Health System, SUS. We have been assessing HTA there in the beginning when Rebrats started with the regulation. Today we are one of the centers for HTA, and we perform the 3 activities with HTA before the Ministry of Health. We work with the clinical protocols and health economy and other arm. Despite being one of the researchers in genetics, we work with cardiology. So I will try to adapt and talk about our global experience with the HTA in genome and genetics. a bit of our organization, our scenario, so that we can be located. What are the trends in precision oncology? What the evidence have been telling us? What are the kinds of tests that have been impacting countries and other HTA agencies? The context in Brazil and other global initiatives and national initiatives as well. As an introduction, although the genome sequencing is recently, it has a great potential to impact the whole waterfall of cancer patients since the diagnosis until the treatment. There are many treatments on specific mutations, and this is what you can see in this picture. From some patients, there are some variants that are respond different, and there are some cancers that will be treated with specific mutations. From 30 to 40% of patients with advanced cancer, they go through tumor genomic profile that has a clear mutation. And then we can have a directed therapy. This is data from FDA. And other agencies tied to HTA will have that as well. In order to use HTA, we need to ask, every changes in genetics will generate important gains. Are they acceptable on the cost point of view? This is where we will have HTA involved. Now talking about trends in oncology. New generation sequencing. They are an alternative to work with a short chain of genes. It is related to more preliminary phases of assessing DNA. And the second part of this study, we will find references at the end. It can be more economic comparing to some tests, PCR tests or other tests as well. In situ fluorescent FISH. I will show you context for Canada and England, and we do not see direct evidence that tie NGS to better clinical results in oncology. They stop in the diagnosis. They do not follow the patient. They do not assess important outcomes in practical terms. There are many kinds of testings that involve precision oncology. We have NGS, RNA, Sanger sequencing, RT-PCR, FISH, and IHC. They are used in sequencing. They cover small parts of DNA, and we have the whole genome sequencing, which is very, very expensive. Agencies discuss directed postal code, because depending where you live, you have more or less access to this whole genome sequencing. We see this in Genomes England that created our sequencing in Brazil, and we have some possibilities with the whole genome sequencing because it's a populational triage. You have a photography of the population to have improvements and to advance some costs as well. What the evidence say is poor. They have devices and diagnostic interest group. They assessed 5 countries: Germany, States, England, Canada, and Australia. This is not a new article, but a very interesting one. They focused on molecular diagnosis. Garfield is the author in 2016. There's no clear rule on which diagnosis need a formal HTA. The studies of diagnosis are the cross-sectional ones, and after assessing diagnosis, they do not continue the research. For example, the patient can have a positive result, do not present the disease, and afterwards die. And all of these can have different outcomes. There isn't a standardized approach, and these tests do not have a global guide on how this is performed. The guidelines are not clear, especially when you think outcomes, result-related outcomes. This AGTR, the impact of AGTR recommendation on reimbursement is not stated as well. I don't remember the acronyms. This is why you see the flags. They are diagnosed the 3 scenarios: places where you have AGTA process for precision oncology, for any precision topic. You have an ATS process that does not differ from the common process. This happens in Germany and Canada. In the middle, you see specific diagnosis, how you deal with diagnosis issues using HTA, and there are other scenarios. For example, the NIH-related group connected to the USA. This is redirected for the personalized medicine and genetics. In England, Germany, and Canada, it's not mandatory that there will be the reimbursement of technology. In Australia and US, reimbursement is mandatory. At NICE is optional, and the US is optional as well. There are many ways of inserting this. There are different redirectioning, considering AGTA encompassing. Still talking about eSPOR. What are their recommendations? The AGTA requirements should be harmonized between national regional AGTA groups. They should improve the access to molecular diagnosis, and there's a limitation to use published reports because the speed of technological change is so high, they are obsolete very, very fast. We should have a living, alive AGTA. Now there's a summarization from this table, from this article, but articles talking about AGTA and precision oncology, they talk about RWE a lot. How studies propose assessment should be done in this context. They should use clinically relevant outcomes, survival, overall survival, among others, focusing accuracy parameters and timing on the access or cycle of feedbacks as well. The monitoring of technology in this area can be very complex. It's updated very fast.
For those who have been through pandemic, I think it's not that dramatic. I think we can get to know. One day we were watching 2,000 articles, another day 10,000. In some specific context, in Canada, an article talks about the fragmented supervision of medical assistance related to this precision oncology process and the lack of clear processes to support HTA. They simulate the use of WA and access of equity, thinking that this process can be better used in some regions than others. They mention the financial aspects, and there's a worrying point. The advancements are quick, they involve small groups of patients and are assessed out of a controlled and randomized groups. Validity, clinical validity, analytical validity are suggested. Is a system health with an incorporated technology to raise data and then decide if it's going to change or being replaced. In this study of Simon's, he mentions an initiative that was the Tango student study. He says that they thought of 3 layers of evaluation: micro, medium, and wide. And he mentions what is study objective: to determine the value of genetic sequencing treatment, in this case with the pulmonary cancer, and then the treatment from the genetic result, and model treatment in short term. And because here we're talking about mutation, and this goes to the level of patients, and the study of effectiveness compared to standard alternatives. Also analyzing aspects that are ethical and social. With genetics, it's more complicated. If you send genetic samples out of Brazil, you need authorizations, and you have many other documents and complexities. And today we have the general data protection also. So genetic data is very complex, and they can use much space. So we need an agreement of the patient for every research and assessment you're going to have. So this is complex as well. Regier is talking about managed access. We would have managed access starting with the introduction of the technology in a system, then data collection of real world with external data, and after the analysis of this real world with cost effectiveness and reference values, and then you block or you decide. You can either change or add or substitute. So, and it also suggests a kind of study that is ideal, rethinking the context of real world. Yeah, it's a little bad here. You don't see anything. I'm gonna try to translate here. These 4 boxes here show patients with biomarkers, identified biomarkers. Then down there below, these patients are target group. These are the ones that are going to have the intervention. Then the 3 boxes below are patients with positive markers and with biomarkers that are negative. And his suggestions is to have a pool of these patients. So by pairing by score, you would pair these populations and analyze outcomes from the point of view, the clinical point of view. Survival by quality of life, and the financial benefit, that is how much you valorize the investment on this treatment. So the more positive you have, the more you are adding value to the money, and other process of survival. About technology and health agencies. The Conitec in Canada, let's say that the limitation, there is a limitation for these processes. So in 2003, they started a watch list that presents 10 technologies of precision technology, and some of them are on oncology. And there are some worries that have been raised. We have some inequities and complexities that have to be considered. Mostly thinking of some tests that can be submitted to polygenic and need complementation of other tests, depending on each place to qualify this test. Some opportunities in this context in Canada. They have created this network for healthcare system called CLIO. to support the development of these structures. It's like a huge platform of real-world data that are incorporated and assessed throughout the time, along the time. This is what we have, I have shown, just like I've shown you. And also about repay based on results. They have had this report on congenital anomalies focused on the sequencing of DNA. There was not a recommendation, it was just a critical review. In the text, nice, we don't have HTA that is precisely referring to oncology, but some references are, some of them are recommended. Here you have Biotime PCR. We have the COBAS from Roche for womb cancer. Exoma, you have many of these treatments on this chart. There are some more particularity as well. I was discussing with a colleague. From the point of view of HTA, the technician needs technical support. The doctor needs technical support because we can sequence codified and codifiable and no codified sequencing. And it's so expensive. We can do an exoma having the introns or not, or you can have hybrid strategies. Our studies in Brazil for cardiovascular studies, we use WCS low pass complemented by exoma at least 30 times plus inputting. So we have the validity of the data. For example, if it's from your country, if it's up to your country or not. Many data, much data from genetics point of view. Contextualizing with our Conitec scenario, I was talking to Carol about that, I've highlighted in bold the assessments of technology related to oncology. There are no complete sequencings, but there are some molecular tests, hybridization in situ, and up here, the FISH for multiple myeloma and detection test for AGTR. Some curiosities. This area is so incipient here in Brazil that we need to establish a little more closeness with technology areas to study and evaluate and assess, because there are some disagreements. For example, the leukemia treatments have been introduced early at SUS. The suggestion was to start with imatinib if you had an increase in the mutations. If you would have a low response, then you would change the inhibitor. But they didn't have the test. They had the medication, but they didn't have the test. This was done after, later. Same happened with doctinib and jectinib for lung cancer. Just now we are assessing the detection of the test for the mutation. So it's a very complex scenario for us, even for other countries, for developed countries. We also have some neglected tropical countries mutations. Some procedures here at the SUS chart. We have sequencing of exoma and DNA with repay value that is 0, because this is in the case of rare diseases and not for the whole population. At ANS, we have the guideline DUT 110, and then we have 0.7, 1, 2. The highlights are 0.7, 23, 24, and 47 that are related to oncology. So we have molecular analysis, FISH, PCR, stability of microsatellite. Forecasts. I have carried some search to check how we are at oncology. I got the keywords cancer and genetic tests, and I selected complete studies, and I found 82 studies. Quickly scanning through them, I can't talk about results because it was really quick. I found 2 eligible that are more related to comparable studies. We see that there is a willingness in studying this. And now, going to the end, we have some global considerations of initiatives of HTA process. Genomics, B1MG, and also Genomics England, that was a precursor that inspired the Genomas Brazil, is our national policies of genomics precision. And this is our study that we have a project within German hospital. And there are some other studies such as rare genome at Albert Einstein Institution. So this is a big opportunity for us. The goal for Genomics England that was to sequence 100,000 people, it's the same in Brazil, but it's still starting. We need to define a lot of things. But we have an opportunity for data generation to have a triage from birth. And then to predict expenses for high-cost treatments in the future. Here you have some references, and I can leave my presentation to you. Thank you.
Agradecer a palestra.
Thank you for both of you. The two of you brought some challenges. The precision medicine is challenging us both in Brazil and also in other areas, and to the people who are conducting the studies. So we see the speeches, the talks from since Maria, we see that we need qualification, but we need data. We need data collection so that this becomes information and become evidence to retrofit these models that are being proposed in HTA, which is a new life cycle of technology, to conclude that we have over the models. We are going to refeed these models with evidence of the real world available at that moment. But to retrofit, we need this data that are systematized. We need information systems. So these are the challenges. We're going to open to the audience, and after I'm going to approach myself.
Bom, gostaria de
I'm a Professor Gisele of Pharmaceutical Faculty at USP. I would like to thank for the lecture of Dr. Ana Carolina and Haliton. Very, very clarifying. I would like to have one question for each of you. Ana Carolina, Conitec receives mostly these demands from pharmaceutical industry for incorporation? And if it's from pharmaceutical labs, if they are the main public or audience that is demanding, is there the possibility for Conitec to condition this incorporation to SUS according to the result throughout a certain time range, and maybe have this accountability on the pharmaceutical industry to have the pharmacovigilance to renew this permission to be privileged by selling to SUS? Because the fact of being first in the United States and secondly in Brazil, it's not just a coincidence. It's because Brazil has this legislation to allow all the Brazilians to the access of universal health services. So of course the pharmaceutical industry is crazy for Brazil because they know it's a guaranteed market. And for Dr. Aliton, sorry about your name, Dr. Aliton, I ask myself after you said, all of you have said, the ideas, the insights you have added, and what's going on in the world. But bringing this to our reality, where we have no way to have technological protocols to evaluate clinical protocols throughout the country. In your opinion, as a specialist, do you think it would be more productive investing in this information, the creation of this huge volume of data that shall not be that productive as it was disappointing, the discovery of the human genome? We thought we would discover the cure for all the diseases at that time, and it didn't happen. We know that today the exomas give one answer, genome gives another answer, proteomic gives another one. There are many things that the giant amount of data won't be able to process and to understand and allow these advantages of predicament for the future, for health direction. So we had to start by improving our communication system, our internal communication of SUS, and have a pharmacovigilance, a better pharmacovigilance. Any other questions? Good afternoon. I'm from Fiocruz, Carmen Romero. Congratulations. I'm coordinator of one of the NATs that collaborate with the ministry. My question is a reflection regarding this dynamic of commissioning, the importance of tracking and the role of diagnostic tests in the early detection and prediction and prevention. As Fiocruz, we have some basic research. We have proposals ongoing for molecular diseases, studies. So we have the question, within the ministry, how does this relate? This is more a reflection. How can an area that work with this evaluation somehow is related to the assistancy that is in charge of the protocols that have been mentioned? Because sometimes the research goes from one side and then the assessment goes to another, and at times it's needed that the change can be done or thought from the organization of the control of the disease, especially from oncological diseases. What I want to say is that we produce science, but it's not clear on how this is going to be applied in the implementation of the health system. What's the role of molecular tests? If it's a replacer, it's going to be part of an algorithm, a new diagnostic algorithm. In this sense, if within the program of the ministry, if there is this communication among the areas or between the areas, if there is a process, if this is on process or ongoing, because each time we see novelties or new technologies for tracking, for the health of women health, we see this a lot. We've seen this morning there are causing higher incidence of mortality, because it's a very relevant role. That's it.
Essas aqui, e aí eu
And questions, they will answer these ones. We only have 5 minutes from the next presentation. Let's be more direct when asking questions, okay? So let me start. The demand or regime. The last data I remember is balanced by public and private sectors. But now 55% is in public origin, comes from the Ministry of Health or other secretariats or public institutions in general. We estimate to have a development of incorporated technology. We are having a provisory incorporation, and we have a subcommission at CONITEC, which is Subcommission of Managed Access. But this is still incipient. We have been discussing a lot. There are many logistic challenges, legal challenges, because of the public biddings. We want the companies to be held responsible to show how their technology will promise that. But they are not the only ones doing so. We need to follow these procedures. How can we put both of them together? So we have still discussing it. And these subcommissions are existing already. In the subcommission, they try to see the cases where we work with the industry and also matters where system sees that need to be followed closely. Specialized assistance, healthcare, primary healthcare. And there's an important part which is monitoring. With or without the industry, it's a monitoring. And we have been including not only this effectiveness information, but today is very important the patient's journey for the access to health system, what the patient needed to do in order to be granted access. This is what the subcommission want to do, to include these outcomes and these indicators. But this is only a perspective and not a result. This is a promise for the next event. From the first question on the computing protocols and if it is worthwhile investing, it's important to understand for many cases, genetics alone is not something big. For example, arteriosclerotic disease, Caucasian population are affected because of lifestyle, diet, if they are smoking or not, alcohol and all. In Genomas Brazil project, we need to have a minimal collection of data, metadata. Other than genetics, we need more data to have information of quality. These are incipient discussions. I participated from some debates. Genoma Brazil will provide information. I have 4,000 of genomes in my bank. And this cloud structure, these servers, how will they get to store petabytes? And today we have big research platforms working to build Genoma Brazil, but they are fragmented. Different goals, results, data, they need to be harmonized at some time. And we need to develop dashboards for fast diagnosis. People with risk of imminent death, we need to detect that. I am talking about Biomerrier panel of meningitis. They spot 17 panels in 1 hour. If you took too long, the patient could die. So I think it's feasible. It's complex, but it's able to be done. We are in the right track, but we need to speed it up. Fiocruz in Bahia has been supporting the Genomas Brazil in structuring this data network. They will receive people's genomes and they need to store these kinds of files that are there. Regarding protocols, I have been working with protocols with the Ministry of Health for a long time. And I'm a bit frustrated because sometimes medical societies do not know about SUS protocols. And without a doubt, our protocols are done the best way. We have methods as nice as CADID in Canada. Sometimes protocols are not done because of budget and other things, but we can follow the processes. Medical society, when they talk about their own protocols, they are not worried who is going to buy. The guideline says who is going to pay. But in SUS, there is the cost and the window of opportunity. If we pay for that, other people will be without budget. We have an assessment to see the implementation of protocols, and we were frustrated because from 5,000 cities in Brazil, we had only 200 answers. And we didn't understand why this happened, because we sent emails asking for the replies. We did many things. So there's a kind of work that needs to be done in order to make these protocols effective. But thinking on care, they are very effective. They are good, but we need to think how to implement them. Any other questions? So thank you so much for the panelists, and let's go to the next lecture. Thank you.
Acho que eu vou convidar o
I'm going to invite Professor Wanderson, and Gustavo is already here. You can come for our panel.
Você tem uma chave USB, você quer passar por aí? O que você prefere? O sinal eu mando por e-mail.
Acho que é melhor.
Deixa eu ver que é bem grande. Qual é o e-mail que eu mando?
É EETOP.
Você quer anotar aqui?
Quero.
Eu tenho uma coisa em francês, tá?
Onde eu arrumo?
Ponto. Isso, né?
Segura? Segura?
Segurando.
Enquanto eles colocam a apresentação.
Let me start introducing Professor Wanderson. He is professor at medical school at USP. He works at ProCentral São Paulo, and he's a senior researcher in Butantan Institute for Cellular Therapy. He will talk to us about design of clinical trials for precision oncology, model with CAR T cells, talking about robust evidences in selection of patients, results, and cost effectiveness. Afterwards, we will have Dr. Gustavo Mendes. He is Director of Regulatory Issues, Quality and Clinical Trials of Butantan Institute. Thank you so much for both of you. Good afternoon, everyone. I would like to say thank you, Patricia. My files are big. We are trying a way to show you. Thank you so much for the invite. I will talk a bit about CAR T cells. I hope you know what a CAR T cell is, but I will provide a lesson on CAR T cells because this is a relatively recent strategy in Brazil. The first pharmaceutical products were approved very recently, last year, when we started using the CAR T cells, which is a Novartis product. This year is a Kite product, and now a Janssen product. So these are commercial products. They are individualized. So the therapeutic is very precise. We remove cells from the patient. We modify the cells genetically in the United States. And these cells come back to Brazil and they are infused in the patient. So this is a new technology where we change the cells from the patient. So I will talk a bit on the diseases that we can use this new therapy. So there's a huge interest in using this kind of approach for other kinds of cancers. There are some scientific data showing neurologic tumors, but it's still in phase of clinical trials and they are not clear for use yet. Very recently, 3 weeks ago, CAR T cell was cleared for use for a specific synovial sarcoma. So we are using this new therapy in solid tumors. The other ones will be coming. CAR T cell has been used in non-oncological diseases. Which ones? Do you have an idea? Which diseases we can use CAR T cells? A disease that is not oncology. Lupus, refractory lupus. So there's a recent publication. Patients that had used every kind of therapies, when they received CAR T cells, in 3 months' time, they weren't using immunosuppressors anymore. There are other approaches, a myocardium fibrosis, infectious diseases. It is a new therapy, and it's very important that you are aware that this is a technology that came to be with us for good. Let me talk about these clinical trials, having CAR T cells as a model in order to assess the problem of these new therapies. A big problem is the cost, and there is a need to have pharmacoeconomic studies to know where we are going to use these therapies. I do not have any conflict of interest regarding this presentation. This is an old slide. The first publications regarding CAR T cell in clinical practice comes from 10 years ago. The first patient was in 2011. He was a chronic lymphoid leukemia patient. They received these genetically modified cells, and other studies showed the efficacy of these cells. What is the rationale of using T cells modified lymphocyte? There's a cell called TILs. T from T cells, So they are lymphocytes, and they are infiltrated in tumors. So this was observed in biopsies. When we see a biopsy of a tumor, the organism tried to defend this tumor by infiltrating lymphocytes. The organism tried to fight that cells and they are massy cells. This is why we have the lymphocytes that infiltrate tumors, and afterwards we had a lymphotherapy. All of this starts with studies, science, and then we see the treatments. So 2011 was the first study. Afterwards, we had an ALL child being treated. You see Carl June in this slide. He's a researcher from Pennsylvania in the US. He works there. And after many studies, there are some questionings from Dario Campana that has already started CAR-T studies. So the first time that this is the first time where he published his study, and we have this child that have a relapse after having transplant. Their parents approved the study, and this child was the first one treated because for leukemia. They created the Emily Whitehead Foundation, and she is celebrating 10 years of cure. She was diagnosed at age 5. She was treated with an unknown therapy. And people from that time saw after the cell infusion, she developed a 39 degrees fever. This was a syndrome of cytokine liberation. And then with the treatment, she could be alive, and she created this foundation. It's such an emotional topic. So CAR T-cell therapy is there with multicentric studies showing that this treatment is effective because CAR T were redirected with the antigen that is present in carcinoma and another inflammatory diseases, and there are many studies I will show you. The blast of the leukemia, which is the most common cancer in the child, which is CD19. It was an ideal target for the CAR T-cell therapy because CD19 is expressed from the ontogenics of cell. So we could see an antigen that would be attacked and would be present in every blast of B cells. This is why we say B, because there is CD19. I receive emails every day asking about breast cancer, my mother is dying, there's metastases. So we are obliged to say, for now, CAR T cells for 3 kinds of oncohematological leukemia, B-cell and chronic problems, lymphoblastic acute of cell B, non-Hodgkin, and myeloma multiple myeloma. In hematology, everything comes first. This is why I'm passionate about oncology. CAR-T, we pick up Dr. Cynthia likes coagulation. You pick up the T cells. Why is it chimeric? It's to mix things. When we talk about transplanting a patient, we say he's a total chimeric. I don't say that hematologic cells are from the patient, but he's a total chimeric. So we have a chimeric receptor. We pick up the cell T and put a B cell receptor. This is why it's a CAR T, chimeric antigen receptor. Now I have CAR macrophage, CAR NK, CAR dendritic. There are many studies being done at USP. So the first generation didn't work. We have a co-stimulation molecule. In the second generation, this molecule changes everything. You have genetic engineering, a co-stimulation molecule. It can be CD, it can be TB. A third generation, you add another molecule. And the fourth generation is a second generation associated to another genetic change that will stimulate or inhibit that lymphocyte.
We have studies in Brazil called truck, which is the car that is for car, and the truck that is from a lorry, that is in English. Most of the studies are from car of second generation. Here we have two commercial products, Axicel from Cartilaide. Yascarta is the Axicel. It's a retrovirus because we use a viral part to modify this genetically. And the lentivirus, that is a cell which is from Novartis. As you see at CD19, this molecule can vary according to the product. When the patient has an indication, we have a leukapheresis. We remove the lymphocytes of the patient. We get those lymphocytes. We modify them genetically. We send these lymphocytes to the lab. They are incubated with viral particles that are going to express the circuit 19. These particles are going to enter the cells and make them express this CD19 that you desire. After they express this CD19, they are going to be expanded in vitro so that it can be activated. And after that, and this takes 2 to 4 weeks within the laboratory, then you are going to infuse in the patient. So you need a chemotherapy with that. After you fuse those cells, the patient will have a oxytocin release syndrome, which is a fight between the cells, the tumoral cells, and these other cells. So you're going to have 30 to 40% of these patients will need intensive therapy. So you have to control. And there's also a neurological syndrome. I had a psychiatric patient. She wanted to hit everybody, but it was just throughout the syndrome. Another patient of 79 years old, she got epileptic. She was 3 weeks intubated with this neurological syndrome after this infusion. These complications are more immediate. They occur usually within the first 15 days. And now we have the other ones, ICAT and a Parkinson-like and some other types of CAR. So in our lab, we have revised systematically on clinical trials everywhere in the world. We've done this at the Lean in the laboratory I coordinate, and we've included in this study 868 clinical trials using CAR-T. From these studies, we can see most of them, 460, were held in China, in the United States, and in Europe. In Brazil, in this time, there were just 1 or 2 studies being held, but they had not been registered. What we've seen, you see here the clinical statuses of these patients. Most of them are phase 1 studies or phase 2 studies. A few of them are phase 3. On the other side, you see those who have completed and those who are being recruited. In terms of funding, most are unicentric or multicentric. But we also have the autologous CAR-T. But we have allogenic studies today. You have a donor, umbilical cord blood, donating NK to make CAR-NK from umbilical cord. This would be ideal because we can have this in a shelf and people can purchase this with the antigen they need. This is his experimental phase. We have CAR-NK from umbilical cord, and Takeda bought the patent. So the CAR-NK from umbilical cord is going to be in the market, and most of them are from pharmaceutical industry. Here you can see very well, but the type of disease in the first graph, most of the diseases are Hodgkin's, lymphoblastic leukemia, and others, hematological diseases. What they want, they are investing on the CAR-T investment, mostly persisting in this CAR cells. Regarding the target type, but most of them have one target, but there are some ones that have 3 targets, because when the patient has a relapse, it's best to have a triple CAR-T. And here's also the type of stimulating molecule. I'm not going to go into details of this, but most of them are CD19 and DCMA that we are going to talk about. For solid tumors, various studies are going on, mostly in glioma and glioblastoma. They are neurological tumors that are very serious, and some results are showing that CAR-T can be a solution for the increase of survival. The conclusion of this study, China is ahead of the United States. There's a huge potential not only for oncological diseases, but also in hematological diseases and no hematological diseases, and also infectious diseases. In Brazil, the commercial use, Novartis product, Dutiza, US Carmila Mambuch, and here you can see in the United States you have various other types of CARs being produced. For example, Brexu, which is a CAR-T directed to a specific lymphoma. The Niju, that is proven efficacy in the cell B, but in Brazil we have only these products that are approved by Anvisa. But there's a problem. There's a toxicity in finance. Look at the price of the product. 2.5 million, the Kymera Novartis. The Johnson Clag is 2 million. And this is only the product, no hospital. This is the problem of having an individualized treatment. 75% of Brazilian population has no health insurance. They belong to SUS system. Even the ones who have health insurance, they are going just by a legal way. They are not paying for the amount of these treatments. How can we work this out? How are we going to treat the people you know and we know us as Brazilian society? we've calculated how many Brazilian patients would need CAR T CD19 in Brazil, considering that we leave CAR T to the last line of treatment. We know that 80% of children with lymphoblastic leukemia are cured with chemotherapy. 20% are going to relapse. So we have all these steps. So we were exercising some estimations on the number of patients with B cells lymphoma, and you can see that considering all this, that in Brazil for this situation of lymphoma and leukemia B, 1,800 to 2,200 patients per year. How about myeloma? We leave the CAR T to use after relapse, but we would need for those relapsing, the one that are autologous transplant non-eligible. So we would need 4,000 patients. In Brazil, we started having some initiatives in some universities, INCA, UFMG in Fortaleza, Albert Einstein, where we have a clinical trial ongoing in the clinic hospital, Hospital das Clínicas. But the most important is the consortium between São Paulo universities and Butantan Institute, where I am part of. And I thank Gustavo, who is Butantan partner as well. With the CAR T CD19 platform started from the Hemocentro Foundation in Ribeirão Preto, today we have the collaboration with the Butantan Institute and the University of São Paulo. We've created 2 plants of manufacturing cells, one in Ribeirão Preto called Nutera, in Ribeirão Preto, and in São Paulo another one. If you want to visit, it's behind the University Hospital. Here's the Nutera in São Paulo, which is a building of 3 floors, which was the old NuCel, where we have the whole structure to make up the cells, but we haven't started at Nutera São Paulo. In Ribeirão Preto, it's ongoing. It is a huge building with various laboratories following all the production line guidelines. And here's the pipeline of what's going on for CAR-NK, halogenic CAR, and CD19, and all the manufacturing of these cells. We've done, Ribeirão Preto started in 2019. We started producing CAR-T. One patient was infused at that time. He was a 64-year-old patient who had been treated many times in other treatments. In September 2019, he received the first infusion. He started in remission, partially. Unfortunately, 2 months later, he fell out of a ladder, stairs, and he died. And in the pandemic, he had to stop the process. And we got back to this work recently. After we can talk about the release of these patients by Anvisa one by one. This is not ideal, but this is the way we have shown how the cells work. This is a patient that has been treated by me and my team. He's 26 years old with LLAB, various treatments, transplants, etc. This patient showed a remission, total remission, but 9 months after he had relapse, but he's alive with the transplant. Throughout this time, he's graduated in medical school, and we've been playing volleyball. And this patient 12 that we treated at hospital, the 2 patients, they have the same disease. They are surprising diseases. This patient, there was nothing to be done, and he sought me the only solution was CAR-T. He started in March 23. After the CAR-T, we see the full vanishing of the disease. He's been playing volleyball in a beach in Rio de Janeiro. So after in this year, we had these 20 cases of compassionate use in 2024. These patients of lymphoma, and they started the remission with the manufacturer of CAR-T cells in Brazil, the academic CAR-T of local production. With these results and all these enthusiastic results, the Ministry of Health released 1 million real to studies. We have 4 patients to be 81 in Ribeirão Preto, and Ribeirão Preto will send a report to Anvisa. We're going to have 5 centers here in São Paulo at Hospital das Clínicas, Ribeirão Preto Unicamp, and 2 private hospitals, Sírio-Libanês and Portuguese, Beneficência Portuguesa in Brazil. And these studies are ongoing, and the objective is to show that these cells are non-toxic, and we can take this to SUS in 1 or 2 years. How would it be costing to us? I've made in-depth calculation. About 10% of market amount, approximately 10,000 real. How about multiple myeloma? I've brought myeloma to the building in São Paulo, Butantan. We agreed that the CD19 would be in Ribeirão Preto, and the other one would be here. So this is a bone disease. It starts with tiredness, fractures, and many bone diseases. It starts with lumbar disease, and it takes a long time to be diagnosed. We have the CRAB, which is the myeloma group of diseases. When I started in hematology, we knew that when they would die very fast, the patients. And there are 25 new medication approved. This disease has no cure. There is a multiple myeloma because there are many chromes. The disease comes, and when you have under 65 years old, you have an induction treatment, you have autologous transplant, and a follow-up, and the disease will come back within a few years. Then you have another therapy until the moment is going to die. So we have the first line, second line, third line, and there you go. The population is mostly elderly, average 63 years old, but 60% is going to be eligible for the transplant. Autologous or not because of the age. So the older patients, the prognostic is a little worse. And what are the medications? In the private system, if I'm treating them at the private system, we have all these therapies available. The last one, even in the private, the last one is CAR-T for myeloma. And what have we got in SUS? Until this period, we had nothing. In 2021, we had bortezomib, which is essential. When I was in England in 2011, we used bortezomib when ICE approved for kidney cases, and today is the chosen treatment for patients. So we are very late at SUS regarding the treatment of myeloma. Personally, I think it's very hard for us who work at SUS and work for the private system. We know there's a 20-year delay just for a few minutes of distance. Hard. And what's the evolution of the treatment? As you can see here, all the drugs the possible drugs. We have a mix of treatments. This is the treatment for multiple myeloma. I talked about CAR T cell, which is the BCMA. That is a surface that we know is a target for the multiple myeloma. We have also various targets, very interesting targets. You see they run around the cellular therapy in the market. I'm not going to go into detail about that, but we can show you later.
And of course, the big studies published all around the world. Cilta-cel, which is from Janssen, we have it in Brazil. They are in a phase 3 study. When we use it compared to the standard care, we triple the survival. And they are talking about curing it for good. There are surprising results. And the Clínicas Hospital in Barcelona decided to have their clinical trial. This is the Spanish model. European system, as they pay very expensive for that, there was a congress about it, and the countries have been investing in their own CAR T-cell study. Italy has invested 330 million of euros to have their CAR T-cell product. Spain started through a donation from a family. The child would die from leukemia. They donated, and then Spain could have their own program to produce their own CAR T-cell. When you compare these 30 patients treated with CAR T-cell of myeloma in Spain, when you compare with the US, the Janssen one, the results are very similar. We have been collaborating with Barcelona to have these. And then you ask, we do not have all those drugs. How are we going to have the CAR T-cell? Then we tried to find some data to show that it's worth it to have CAR T-cell over other drugs. Medicine for myeloma, they are so expensive that the amount of a year treatment with the normal protocol, we can pay CAR T-cell. I'm not going to dive into the details. We have huge work in Butantan to justify the use of these treatments, but we can produce CAR T-cell with a lower value. Here you can see the therapies protocols. Suppose after autologous transplant there's a relapse. The treatment will vary between 2 to 3 million reais. In 2 years treatment, 2-year treatment with a monoclonal antibody called Abdumunab. So a scenario of Barcelona vector, we would produce CAR T-cell for 264,000 reais. It's only one infusion. The patient wouldn't have to be admitted to hospital long compared to the other medicine we use to treat myeloma. And what we want here with this product from Butantan compared to Barcelona, we wish to have a CAR T-cell from a previous line to avoid this expenditure, a posterior expenditure that would be very high. All this estimate was done with the Butantan economic team to justify such a huge investment for CAR T cells therapy for multiple myeloma. If you wish to get to know Nuterra, these are the pictures. We have the complete set of equipment necessary. We have CNPq financing to validate this Barcelona project here in Brazil. I have 10 minutes. I'm going to wrap up. We have a CNPq project that will make us validate our research. And I have a student going to Barcelona to learn this new technology. We have this project in partnership with Barcelona. Short term, we will show the CAR T cell we produce here is the same than we have in Barcelona. There's a clinical trial of phase 1, phase 2 we wish to do. We need to find financing and long term. This is midterm and long term, make it possible in our unified health system, enabling the best treatment for the Brazilian population. Thank you so much.
Obrigado, Wanderson, pela apresentação.
Thank you, Wanderson, for your presentation. I'm the moderator, and I'll make some comments as well to complement what Wanderson has just said. There are some pieces of information that they call my attention. First of all, the financing study showed we can produce this kind of technology in Brazil 10% the amount of the cost of the product abroad. This is appealing. This kind of product was discussed in Anvisa, if they would regulate it as a service, a health service or a health product. There were difficulties because we needed to see how it would be produced. We needed to remove the product from the patient, use specific equipment to make the change and reinsert it into the patient. So we could conclude that at the end, the best option would be to treat it as a product, even if the regulation for products implies different criteria, such as good practice of manufacturing, definition of batch, expiry date, conditions of storage. In a service, we wouldn't need to have this kind of analysis. With our regulatory framework for advanced therapies, as this was consolidated in Brazil, we are in a different moment. The Ministry of Health has already signaled that some therapies are considered strategic. They are interest for Brazil. So they encouraged this kind of projects on financing for structure for the lab, so that the teams are trained, so that the clinical trial happens, and also for the internalization and incorporation at our health unified system. On that note, I would like to listen to your considerations and your questions, you the audience. Pandemic made something clear. When everything is priority, nothing is a priority. From the Ministry of Health, we needed a list of products that are considered strategic. Advanced therapies, especially the CAR T cell therapy, was considered a strategic product because this is an already approved product, the cost is high, and there's a population that will benefit from this kind of therapy. When this is defined as a priority, we need to move, to work. And Butantan Institute in this project has been looking for working for this internalization. They have been working hard for that matter. The studies that happening, and this is a very important market and a very the money that come from this is high. Academic products has a value in this, but we need to know that criteria to approve this kind of product, this is go to quality, safety, and efficacy. This needs to be done in a regulated market so that this can be subsidized. I will start asking questions so that the audience can ask their questions as well. How do you see the challenges posed by Brazilian normatives to approve regulations and to incorporate the medicine? What do they represent in this future for the cell therapies and advanced therapies in general?
Tem que apertar aí. Aperta aqui, tá certo. Gustavo, você me colocou numa...
Gustavo, I'm in trouble now. My goodness. Nowadays, with our experience, what do we see? It's clear for me. With this phase 1 and 2 CD19 study, it's clear for me. There's a need for scientists and doctors, and for the sponsors as well. From the start, they need to think how to make and have the product available. I learned it. From the start, we need to discuss it with Anvisa, our regulatory agency in Brazil. We need to know where we are getting so that resources are rationalized. People that want to produce CAR T cells, and this is what is going on with CAR T cells for myeloma. You need to have a whole preparation done, bearing in mind that product will be used in human beings. And everything done to meet your demands need to be done from day one. This is the most important message. This is heavy. The regulatory part, the efficacy part. This is heavy work. With the whole discussion with the passive studies, we needed to clear patient per patient. We needed to have many reports. We saw the patient progression. We saw the reports with Anvisa. The last patient I had, I needed to sign a term that saying that I needed to infuse the patient with the cells, and Anvisa didn't clear the infusion because the commercial product was already available. When we have a commercial product, there is this case of the liabilities. We need to think about it. We need to think on the cost. The cells were ready, and this is only an example to show you the difficulties with regulations. As the patient had the T cells ready, and then I received a normative saying that they couldn't infuse it because the commercial product was available. So we needed to see the regulations signed and the people treating patient side. Communication needs to be better between Anvisa and people from the other side of the negotiations table. So I signed the document, I could infuse the cells, I didn't have any problems. Luckily, everything went well. Lawyers weren't involved, she's okay. But this is a problem. This regulatory part is very difficult. Every scientist who wishes to do so, they wish to know how much work is involved with the bureaucracy, with red tape. I lived abroad, and I was impressed how serious people in Anvisa are. I don't say that because you work with Anvisa, but they are professionals of excellence. And we have discussed very frankly with them. And we see they are interested in helping bring these expensive problems to our unified health system. I'm not sure if I answered every question you asked, but my message is talk to Anvisa. Talk to Anvisa before starting anything. You will be redirected to the right path. Now I would like to open for questions. Any questions you may have, considerations. We have two people in line. Hi, good afternoon. I'm Claudia Pavani. I'm a researcher with the EA in financing innovation. I have some insights. I work with startups, generation of new business, and there are some questions in my mind. First of all, about intellectual property. It's not the same product. We have a new process. How is the system to patent, to provide patents? Having the math done in my mind, this is a very interesting business that can be seen by other actors and being copied. But there's a whole know-how process. How have you been dealing with this? There's a possible new chain of business on this topic. How do you think on these matters? Excellent question. In Butantan Institute, I can talk about a case we have been discussing with Vanderson. We have an innovation office. It is dedicated to identify patents. Patents related to this kind of product. There's a way to provide the patent of sequencing this vector. The cell is from the patient, so there's no way to have a patent on that. The process, we can have a patent on the process. It depends on the technique, but the Nutera technique, we use a kind of a commercial equipment, and this is not patented. But we can patent it, but it's a challenge not to harm the patents. But we have an office that is dedicated to it. If we can have an innovation, we need to patent it. And we need to prevent it to be copied. This is something we should be concerned with. It's very interesting work. Your question is very interesting. What is going to change is the building the vector, and then the vector can be patented. The one from Ribeirão Preto was built there and is patented. Now, the other one, the BCMA, was made in Barcelona. We need a transfer of technology to know if they wish to patent it. In the agreement, they said they do not want the product to be commercialized. This is for public health. So this is the goal. So how we are going to make it accessible for public health? This will have expenditure. This is a problem, and the vector is very expensive. From all of them, this is the most expensive vector. The Ministry of Health has been working with a Caring Cross, an NGO. They had an agreement with Fiocruz in order to produce vectors. I'm not aware of every details, but Fiocruz and Caring Cross, they will produce some vectors. They will start with this ONG's methodology, Caring Cross. It was a startup connected to Mutiny, which produces Prodigy, the machine that will produce the CAR T cells. In this agreement, they transferred the technology to build the vectors. In my lab, I have BCMA from this Caring Cross NGO to test it scientifically. but I cannot pass them to clinical trials because of this agreement. So the vector production will make a difference about in terms of production. Imagine CD19, BCMA, GD2 for glioblastoma, and other kinds of vectors. There's a myriad of possibilities of patents regarding building the vector.
Of course, you're going to have a new patent. The problem is the investment in the vectors, because this is more expensive. So in this collaboration with Barcelona, we're going to have to pay for the vectors and produce, taking into account that the vector for one patient costs about $10,000. Of course, it's not the millions of pharmaceutical industries, but it's expensive as well. But it's very interesting because this is a question that Cristiano is really involved in. He has a vision, a very interesting vision on all these patents. My name is Erica. I work in a startup for technology. And I work with Wanderson and Gustavo, professors. The difference between experimental treatment and clinical trials, especially for personalized therapy non-cellular. But they are personalized so that you need an ethics committee. But in other countries such as Germany and China, this product wouldn't have to be approved. This is something for us to think when we consider that studies with animals, if they are ill, they can't be allowed. And we have a personalized treatment. So I would like you to comment about this difference that for us, because we don't know much about it. We call the study, the regulatory study, the one that has been approved by Anvisa. So there's a protocol for study. Suppose it's a phase 1 study. It's the first time the product is going to be tested on humans. The rule today is the RTC 9 of 2015. It says that a sponsor and a research center have to submit this request for approval of the clinical trial to Anvisa that needs to have how the study is going to be conducted, the outcomes, where it's going to be conducted, if the center has the good clinical practices, that making sure that includes making sure that the participant and that center has a trained team with procedures. There is trackability of this study. If Anvisa can see the clinical report and see the lab trial, where this is being held, who collected the sample, who analyzed the sample. This is the regulation study. And it's only a demand when the product has as an objective the registry. This is important, what Wanderson has put. He suggested that people would start thinking of this throughout the research. But not all the products need the registration and become a commercial product. Many researches that happened in the academia are only contributions to science, and they don't need to undergo Anvisa authorizations. The academic trials imply in the participation of people, patients, etc. These studies need an ethical approval. Today we have a new legislation for clinical trial, and the role of CONEP and CEPS, it's undergoing a rebuilding, a reconstruction, but the rule is clear today. If you are having an academic trial, you're going to use humans, you don't need a previous approval from Anvisa. That makes the difference you have asked. the use for experimental use, academic use, it's not going to follow. It doesn't need, ideally, it needs trackability and trustability, reliability. You need an environment of excellence in the research, but it's not going to be inspected by Anvisa. You won't have the rigor of the good practices that is demanded on the regulatory studies. I don't know if it's clear, if you want to add something. Actually, we don't call it experimental study. We call it compassive. Compassive, which is for compassion, is a resolution of Anvisa for using the products in which are not approved by Anvisa but are under investigation, under studies. The defined scenario for the resolution is that the use happens in products that are undergoing regulatory studies, that are in research phases, 1, 2, or 3. Some cases happen. For example, CAR-T Ribeirão Preto was not in the approved authorization, but had the compassive study approved. This happens in very exceptional cases. In the case of some very specific discussions. This context in which this happened, in the way Anvisa has adapted to respond to this question, was innovative. The studies today that are being held in Ribeirão Preto are being followed pari passu by Anvisa, because they saw a good use for CAR-T for a financially neglected situation to the access. But the compassive use is the use of a product that is undergoing investigation. Is that clear? I can't hear without the microphone. For each country you have a rule. I can't hear without the microphone, I'm sorry. Of the approval of the ethical committee, but not the product to have registered. So we started seeking to study these countries. So I'm taking the opportunity to ask you about it here. Well, the complaint in Brazil is because the clinical research law, it didn't change much, but we need the sponsor to supply the product throughout the whole period until the product is approved by Anvisa, or that is made available at SUS. This is something that used to be a complaint from many researchers, because that causes expenses to the studies. The new legislation for clinical trial, there has been a movement for this change, and it's a debate between ethical instances and the businesses and laboratories, because the businesses understand that this is a high cost. And the ethical instances, they think that it's not possible a sponsor to stop supplying the product, whereas it's not available. So this hasn't been solved yet. So this is one of the complaints I see with more frequency. But regarding regulatory issues, this is not supposed to be a block or to be blocking, because it's not different from what we see abroad. Professor Gisele from Pharmaceutical Faculty of USP. I would like to talk to Wanderson about your opinion about the future of this therapy, CAR-T cells, in solid tumors and metastatic tumors. And to Gustavo, I would like a recommendation on how we are developing biopharmaceuticals and biotechnologicals. How can we access Anvisa to have more certain actions? First, about solid tumors. Metastatic. The metastatic solid tumors, depending on it depends on the tumor and it depends on the cell. Studies are ongoing. We don't have solid evidence that CAR T cell works isolatedly for these situations, because there are various issues, biological issues that are important. First of all, the solid tumors that are metastatic, they have a biological structure that is different from the liquid tumors. The CAR T cells that are lymphocytes, they cannot penetrate in that micro environment of the tumor. So there's a physical barrier that is important that doesn't happen in liquid tumors. That's why it works well in liquid tumors. Face the metastatic tumors, breast cancer, intestine, prostate, because these cells, they can't reach the tumor. So these cells are probably associated to radiotherapy or chemotherapy to destroy the tumoral environment, or cell formulas or immunotherapy that reach the tumoral environment. What explains why the CAR T cells are not as efficient in solid tumors? One of them is this. Another one is that solid and metastatic tumors have no antigens that come up. So they are not targets for the CAR T cells. And the tumor cells, they have subclones with no antigens that cannot be tackled. There's a release in the US. The TILs are the lymphocytes that are infiltrators of tumors for myeloma. When I was in the United States, I saw this. You remove the tumor of the patient, you insulated the TILs, and you expand these TILs in lab, and then you return them. This is commercially available. Probably we're going to have other methodologies of immunotherapies. We know of immunotherapies for solid tumors that work. I've seen phase 1 studies for CAR T associated with chemotherapy for prostate and kidney tumors, but it's not the results that we are expecting for the hematologic cases. Regarding innovation in the academia and also startups and other initiatives, the ideal moment in my vision for involving the regulator agency is when we have a product that has undergone a conceptual test. We have already defined a target. We have cellular in vitro models or animal models that are meaningful. And the next step would be non-clinical studies of toxicity, safety, reproductive toxicity, only those hepatotoxicity, all this package of studies of toxicity that are part of the studies that are needed before you start in humans. These studies have to happen in good practices of laboratory. In Brazil, we have a limitation for the conduction of studies on BPL because we have a few places. Butantan now is structuring to do it internally, this kind of study, because it's a study that also demands trackability, calibrated equipment. It's a place where these studies are held, which is a regulatory place. Because if you come after and you have studies of toxicity in your product on non-BPL studies, when you get to Anvisa with the objective of having the study in humans, you will have to complement these studies with the what's missing. Our last question. I'm Rosana Scolelli from Beneficência Portuguesa. Congratulations on your research. I've got the opportunity to visit Ribeirão Preto plant. I was so qualified to enter. I'm very proud of it. My question is, besides partnerships, to have accelerators for molecule development, we have a network of centers that can accelerate the studies in humans would be a reason for what we can qualify the centers. There is this regulatory part, documents that are important and legal, so that our results can be compared or criticized, so that we have international standards. But we have many 5 centers. To have more people, we need more qualified centers. To improve this network for technology, Brazilian technology, together with qualified centers that are being qualified throughout the years. How do you see this throughout this development of this technology in Brazil?
Eu vejo.
After the pandemic, we had a meaningful growth of research centers that fulfill good practices, clinical good practices in humans. The requirements are good clinical practices. This has increased meaningfully. So we have conducted studies for most vaccines and biological products that have been used here. Even subsidized registration of these vaccines out of Brazil. So the level of excellence we have today in the centers is recognized, a renowned level all over the world. The problem, the challenge that stops initiatives is the cost. And the cost we can solve in an instance that is such as the Ministry of Health, that started bidding with PDU, which is in a local innovations initiative to stimulate proposals of innovations in Brazil and opens opportunity for funding and offers resources to hire. So no matter if I'm a startup or a university or pharmaceutical industry, I need to hire centers that fulfill the requirements of regulations and the technical demands for data supply that are trustable. Even in the academia, if the purpose is to have the product to become commercial, we have a structure here in Brazil. We don't need a parallel structure to serve academia. In my vision, it seems that academia is different. No, we need resources to hire the centers that have the excellence to respond to what we need. I don't know what you think. To create a parallel center and credentiate the centers that are able to do that. Because sometimes we have these academic choices. For example, I'm in a private hospital and we see the prices of public, the cost of public services. But we could have internal initiatives to contribute. So I believe there are more agents that can do that if they learn what is demanded to do so. So I would like to know if there are possibilities open to this participation. In this pathway of innovation of universities, I see as important as involving regulation agents is to seek partnerships with those who potentially can produce these medications, molecules, and biotechnological elements. Involving university and businesses, we've had some advance, but we need to advance even more. Butantan is a business and is a research center that can escalate what's being developed on the bench. But there are still Brazilian businesses that can benefit from the research that have been being held in the academia. And the businesses contribute to the fulfillment of requirements in regulations more simply than if you have in the academia to produce a molecule. So this partnership needs to be stimulated, not only private businesses, also Fiocruz and Butantan and other state companies that can be engaged in this partnership.
I think we fulfilled the objective of this first day. I'm so happy with the dialogue we could foster here today with the many stakeholders in the precision medicine area and the HTA area as well. It's very good to see startup representatives, regulatory bodies, HTA bodies, the producers of these technological innovations. All these stakeholders are here together paying attention to the challenges and how to have this available in the unified health system. Have a nice rest, everyone. We will start at 9 tomorrow. Thank you so much, Wanderson, Gustavo, for your participation. Thank you.